welcome everybody. I'm John Coggan. I'm Professor of Law in the Centre for Health, Law and Society in the University of Bristol Law School, and I'm very pleased to welcome you to this event as a co-investigator on the UK Pandemic Ethics Accelerator. Before the conference itself begins, I'd like briefly to say a few words. First, about the Ethics Accelerator project itself, and if you're interested, as I hope you are, you can find out much more if you look at our website, which is ukpandemicethics, all one word, .org. The aim of the project has been and remains to bring UK ethics expertise to bear on the multiple ongoing ethical challenges that have arisen and continue to arise during the COVID-19 pandemic through providing advice, promoting better understanding of ethical questions and contributing to preparedness as we look forward. The project is a collaboration between the Universities of Oxford, Bristol and Edinburgh, University College London and the Nuffield Council on Bioethics. It's led by Professor Ilana Singh and Ilana will be presenting more detail on the work of the accelerator in the session at 1 p.m. And I'm pleased to say that we've gratefully received the core funding for the project from the Arts and Humanities Research Council as part of the UKRI's COVID-19 funding. Now, today's conference is taking place online for its value as a live event with as much reach as possible. Please note as well that we're recording the event and plan to make use of the materials that we generate in order to widen that reach further in the future. The conference title invites a focus on the proper place and visibility of value judgments in public health policy and practice. We're interested to consider questions of principle that have featured or that should have featured in pandemic decision-making, in the making and implementing of policy. Now, this entails consideration of substantive questions, asking, for example, what values should guide policy? Whose values are these? What values should be given more or less priority and why? It also entails consideration of procedural questions. How should the views of different publics, organisations, experts and others be garnered? How should policy rationales and the details of its effects be communicated? How are democratic norms such as transparency to be held? And so on. Now, I'm delighted that we have an excellent range of perspectives to bring in on this, and I'm very grateful to all of our speakers for providing the platform today for a discussion of the different ways that ethics can and should feature in pandemic decision-making. And the event as a whole is structured through 3 sessions. So the first session, which I'm chairing, is entitled Beyond Following the Science, Value Judgments and Transparency in Pandemic Decision-Making. The second session looks at the challenges of real-time public ethics and incorporating ethics expertise in public decision-making. And the final session explores the idea of anticipating, identifying and responding to ethical controversy and uncertainty. Each session will comprise, first of all, a 15 to 20-minute initial talk, followed by 5-minute further reflections, respectively, from each of the other panelists. And then we'll have time for panel discussion, which will incorporate questions from the panelists to one another and summaries of questions from the chat. So please do add your own questions or observations. Before starting the session, I just want to say a few words of thanks. So first of all, I want to say thank you to all of the speakers. Each and every one of them is an extremely busy person, and I'm really heartened by the willingness of the speakers to allow time to share their insights and perspectives today. I'd like to thank the 2 other chairs of the following sessions, Dr. Beth Kamunga Gapodo and Professor James Wilson. I'd like to thank Dr. Alex McKeown for his help in organising and for today for monitoring and relaying questions from the chat. I owe enormous thanks to Kieran Manku, whose organisation and coordination of the event has been invaluable, and similarly to her colleague in Oxford, Alexandra Almeida. I thank Sarah Walker-Robson and Jade McClure at the Nuffield Council on Bioethics for their support and advice and their leadership on communications. Once more, I record our thanks to the UKRI, and of course, I very much thank all of those of you who have come to attend today. So with those words said, let us now move to the first session, Beyond Following the Science, Value Judgments and Transparency in Pandemic Decision-Making. and it's a great pleasure to welcome and introduce Professor Martin McKee. Martin is Professor of European Public Health and Medical Director at the London School of Hygiene and Tropical Medicine. For a fuller record of his biography, please look on our website. But amongst his many roles, we're particularly interested and pleased to hear him give the first talk today, given his role as a member of Independent SAGE, which is a UK group of scientists who seek to communicate evidence on COVID-19 to the public and to civil society. So Martin, I'm very pleased to hand over to you.
Thank you for inviting me to talk to you today. And the title, as you've heard, is Beyond Following the Science. So let me just start off by saying the United Kingdom was in an incredibly strong position at the beginning of the pandemic. If you just look at the science, look at the achievements, and I've just picked up a few: the development of the Oxford AstraZeneca vaccine, the recovery trial, world beating and demonstrating the beneficial role of steroids, and as importantly, that things like chloroquine did not work and the open safely work. And one could go on, the genome sequencing and so on. So from that point of view, it was all very good and very promising. And more than that, if you looked at the Global Health Security Index that was published in 2019, there we are, pandemic preparedness, second in the world to the United States. Everything that we needed was there, at least in theory. But there was one thing, of course, that did not take account of, or one person in particular that did not take account of, and it's this person here. It was the leadership. Now, of course, here we have a political leader. As we know, he was largely absent at the beginning of the pandemic, and then he had to take advice and develop a program going forward. Now, I've written extensively about the weaknesses that we had then, but let's just focus on the advice. The advice was provided by SAGE, as we all know, the Scientific Advisory Group in Emergencies, and this is a group whose membership varies depending on the threat. So it was convened, for example, from the Novichok poisoning in Salisbury and flooding and other natural disasters in the past. Membership was initially secret, as was the advice that was given. And we and others were concerned about the secrecy of this. We wanted to know, were ministers following the science? So we couldn't know that unless we knew what the scientific advice was. Now, there have been a number of criticisms of the system, and I really want to stress that I am not for 1 second criticizing the members of SAGE. My concerns relate more to the position of SAGE within the government advisory structure, but these are some quotations taken from a variety of parliamentary committee reports. It was insufficiently informed by public health experts, by which I mean people who have the ability to synthesize information and evidence from a range of disciplines, bring them together and to look at the responses that are likely to be needed. It was accused of lacking situational awareness and input from the ground. It was criticized for not having sufficient representation from social care, or giving enough weight to the impact on the social care sector, or paid less attention to practical considerations. And of course, this reflected a very strongly held view that science is one thing and policy is another, and the two should be kept separate. Scientists advise, politicians decide, as Margaret Thatcher famously said. But we think that there was actually a bigger problem. And the bigger problem goes back to this famous quotation from Douglas Jay in 1937. The gentleman in Whitehall really does know better what is good for people than the people know themselves. And our concern was that a lot of people who could have contributed to this discussion and to the evidence were not being listened to. So we set up Independent SAGE, and this was a group of people, scientists, who came together to provide independent scientific advice. If the United Kingdom government had been interested, we would advise them. We did advise the devolved administrations and local government and many other sectors. But I think it's fair to say that at least formally, it's not clear that our advice had any impact in Westminster, at least not in the executive, because of course a lot of MPs from a variety, from all parties in fact, have certainly taken a lot of interest. We're a group of virologists, immunologists, behavioral scientists, clinicians, public health professionals and others. And we're committed to engaging with ordinary people, listening to their problems, reviewing the evidence transparently, and presenting it to the public in weekly briefings and in reports and so on. And I think what is crucial about all of this, and I'm going to quote, if you forgive me, from an email that I got from a colleague this morning as we were reflecting on our role. We're essentially a transdisciplinary collective. The checks and balances of and complementarity of routine communication and sharing of expertise and advice creates both the confidence and competence to construct and communicate what is no longer a unidisciplinary contribution, but a transdisciplinary synthesis. And I think that's incredibly important because we spend an hour and a half every Thursday evening and other times during the week meeting together to discuss these really difficult issues. Now, our concern is that a lot of people were not listened to. I've got a little list of people, I'll go through them very quickly, of people we feel that should have been listened to but weren't. So in the interest of time, let's flick through very quickly. Jeremy Farrar famously said, I wish SAGE had drawn on a wider group of experts with first-hand insights from China and the surrounding region. Again, comments from parliamentary science and health committees from their joint report. And because most of my work is outside the UK, because I sit on European Commission expert panels, I advise WHO Euro, I was seeing a lot of this from the other side because I was looking at the challenges of engaging with the UK, and they were profound. We run this COVID response monitor in the European Observatory, and this led to a number of very significant mistakes, like, for example, putting France on the Amber Plus list. That was just a simple error that could have been corrected. Concerned that we were not talking to lab scientists, a quotation from Alan McNally, who was is a leading laboratory scientist who talked about the Immensa laboratory scandal, said, in the long list of COVID disasters and scandals, it's pretty near the top. You shouldn't be relying on anecdotal reports to spot a problem. It's unforgivable. And Paul Nurse has talked about how talking to ministers is like poking a blancmange. The local public health teams were really marginalized for the first wave of the pandemic. Now, this is a diagram that we put together to show the complexity of all of the relationships that are involved. But there were people who had a lot of expertise in local laboratories, contact tracers in local public health teams. You know, contact tracing with sexual infections is really complicated. It requires a particular skill set because you're inquiring into the most intimate aspects of people's lives. And yet, when we needed to build a system, the government contracted with outsourcing and accountancy firms with no expertise whatsoever in this area, and they failed to establish any links to local government, to the NHS or other stakeholders. There are many accounts of how people on the front line felt that they were being ignored. The advice that they were giving or trying to give was not being heard. Health workers were exhausted, and as they said, clapping is nice, but PPE and a bit of respect would have been better. We had the expensive fiasco of the Nightingale hospitals, where people were saying it's fine to build these things, but you need the staff. Where will you get the staff from? And accounts by Rachel Clark and by others. We tried to help in this. We did a paper right at the beginning saying COVID-19 is a complex multi-system disorder, convening people from cardiology and neurology and intensive care and respiratory medicine, because we were clear that this was not just another respiratory infection. It was much more than that. But there was very little attention paid to that. Patients were very substantially ignored. They have repeatedly said that they have not been included in the discourse. There's been a virtual denial of the existence of long COVID, and somebody might want to actually do a linguistic analysis of ministers' statements to find out how often they've even used the words long COVID. I suspect very rarely. And there was a concerted effort by some to minimize the risk of long COVID because it was inconvenient for the narrative about opening up. One group, from the long COVID SOS support group, a shocking lack of attention has been paid to this significant group of people of all ages, and many sufferers feel badly let down. Then there were the essential workers, people who were in precarious employment, the gig economy. There was a real sense that politicians seemed completely unaware of the lived reality of the poorest families. Many of the measures that were put in place simply did not work. The isolation payment only covered 1 in 8 workers. It was very complex to apply for. Care home workers, we wrote a paper where we asked, did the UK government really throw a protective ring around care homes in the pandemic? And I've also recently written a paper looking at the recent judgment, which confirms that it didn't. Again, the parliamentary committees are a valuable source here, saying that SAGE did not have sufficient representation or did not give enough weight to the social care sector. And my colleague John Edmonds has said, I sometimes think we were removed from daily decisions that other organisations were putting in place. I would have liked, personally speaking, a bit more input on the ground. We knew care homes would be a risk, but I remember distinctly the day we first saw the data. Oh my God, there's 100 or so outbreaks in care homes. Dreadful, but I don't think we had such good situational awareness. And then there were the procurement experts. I've been the rapporteur on a major European Commission report on public procurement, started before the pandemic, but it was very clear that we were not learning the lessons from that experience and not talking to people who did have expert in procurement. And instead we had the VIP lane, we had the scandals, with numerous failures, scathing reports from the National Audit Office and from other people. So a big problem there, people not being listened to. School teachers were not listened to. They were getting guidance sent on Sunday nights to be implemented on Monday morning. There was a failure to provide support for remote learning, a program to contract for laptops that never arrived, a failure to appreciate the airborne nature of the virus, a lack of understanding of the challenges of teaching in person. And then, you know, we have a quotation here, the DFE goes on television promising all sorts and telling people this is going to happen, but it's left for schools and parents to pick up the pieces when it doesn't. There was a major problem of disinformation, unfortunately, particularly in the United Kingdom here, with some British paediatricians who were in complete denial about the role of transmission in schools. But there were some people who did have an inside track. I've mentioned procurement. There were scientists who believed we were achieving herd immunity in early 2020 and who had good links to some ministers and also to some backbench MPs and a number of shadowy pressure groups. Now, my argument is that this is actually not surprising given what we know about public policy in the UK. There are some things that have never changed. And the classic example that many people in public policy will be familiar with is the attempt to grow groundnuts in colonial era Tanganyika in the post-war period. Now, this is worth reading at length. It's a wonderful saga of how everything that could have gone wrong did go wrong. But the fundamental point was that nobody asked the local people why they didn't grow groundnuts. Rehousing people into the concrete jungles in the 1960s is another example. And a contemporary example is helping Ukrainian migrants. Nobody asked those struggling with online forms about what the problems were. Those in charge, as you see in this "No Visas Delivered in Calais" sign, seemed aware of the fact that you could actually put web links into QR codes. Frankly, appalling. And so it goes on, and many of you will be familiar with this classic book, The Blunders of Our Government. One reason, the authors say, Anthony King and Ivor Crewe said, one reason that today's British government screw up so often is that ministers are reluctant to engage fully with others and to see them as active participants in the policy-making process. They use example of the poll tax, gestated and born wholly in-house within one corner of the already secretive and secluded world of Whitehall. Outsiders to the government, once they got to know of the tax's existence, were almost uniformly astonished and dismissive. And at that, I will stop.
That's really excellent. Thank you very much, Martin, for covering so much so succinctly. That's really good. And I can see it's already starting to feed and provoke questions in the chat. Before we hear from Martin again, I'm very pleased that we've got two panelists who are going to offer their own shorter reflections. The first is Dr. Cameron Abbasi. So Cameron, if I could invite you please to switch on your camera and microphone. And while you're doing that, I shall introduce you. Again, a longer biography is available online. Cameron Abbasi is a doctor, journalist, editor and broadcaster. Following 5 years in hospital medicine, working in various medical specialties such as psychiatry and cardiology, he has had various senior editorial roles. In January 2022, he became editor-in-chief of the BMJ, and it's in particular in that medical editorial role, but also as a contributor to debates through journals such as the BMJ that we're very pleased now to hear your reflections. Thank you, Cameron.
Great, John, thank you very much. And thank you, Martin, for that really excellent explanation of how things unfolded. I just want to pick up on on some probably related themes, and some overlap with what Martin just spoke about. I'd like to begin with the issue of values, because I think values are very important here. And and it's something we live by at the BMJ, if we can use our example. And I thought what I would do is just think of our values at the BMJ and see how they played out in the pandemic. So our values, that we hold dear are being open and transparent, number one, being evidence-based, in no particular order, being evidence-based, being patient-centered, and being courageous. I think values are very important. I remind our editorial team of those values on an almost daily basis. So in terms of the pandemic, if we take openness and transparency, we can see that, and Martin gave examples of this, where there wasn't openness and there wasn't transparency. We can just think of the example of the contracts that were awarded. Information emerged slowly and belatedly, and after intense inquiry and efforts from a number of people to get at what happened in how contracts, for example, were awarded. And these ran into hundreds of millions, potentially billions. So a lot of money was awarded with a complete lack of transparency. And we now realize that was to many parties who were, and corporations and individuals who were entirely unsuited to delivering on those particular contracts. That was one thing. Another area of a lack of transparency was around science policy. And again, Martin mentioned this. And often, even us that have a bit of an inside track in the world of medical journals, were left baffled as to where the science policy was coming from. And it was SAGE, but also JCVI, the Vaccines Committee. So the policy making, although the government regularly said it was based on science, they were following the science, it wasn't clear what that science was that they said they were following. So I think the test of transparency and openness was thoroughly failed. And then that means that, and I mentioned science, if we look at whether policy was evidence-based, I think we can say that, it probably wasn't. We don't really know entirely what the government was taking to be the scientific advice. We certainly know that there was existing evidence, and again, Martin alluded to this, from the international arena, from the countries of East Asia. I think if anybody had attended conferences and meetings and spoken to experts from East Asia, about their experiences of SARS. And if you went to conferences in that region, you could not escape them talking about their experiences and what they learned to work well and what hadn't worked so well. That somehow the UK and other major countries were unaware of that evidence and that experience. And they were unable to use what was already known about handling pandemics, about handling these types of emergencies. And somehow it came to us as a bit of a bolt out of the blue. And we might take one particular example of asymptomatic transmission of SARS-CoV-2, and the recent judgments related to what happened in care homes. The government somehow denied that it knew anything about asymptomatic transmission. Whereas at the beginning of the pandemic, it was something that people were talking about, the possibility was there. If you'd read the evidence, you'd spoken to the experience of people in East Asia and that experienced other pandemics, you would understand that asymptomatic transmission, of course, is possible. So I pretend that it doesn't exist. It's certainly not following the evidence. So that's just one example. There are thousands of examples. So in terms of following the evidence, it's not clear that policymakers followed the evidence. So they didn't follow live the value of being evidence-based. The third value that we particularly are concerned with at the BMJ is being patient-centered. I think without a shadow of a doubt, we can say that all the progress that had been made towards making decision-making in health systems, including in the UK, more patient-centered in terms of co-creation, in terms of including the patient voice. That all went out of the window with the pandemic, and we went back to the bad old days, in which patients were told what needed to be done to them. They were instructed. There was no co-creation. There was no listening to the patient voice or the patient experience. So the third value we failed on. The fourth value that I mentioned that we hold at the BMJ is being courageous. So you might say that the government or various governments were courageous in their policy making. They withstood a good deal of criticism. And sure, perhaps they did. But I would say they probably haven't been courageous. And I'll give an example from the UK. I think it would have been courageous to have held a public inquiry. That would have been the right thing to do early on in the pandemic, a learning type of public inquiry where we learn from our past experiences and modify policy in the wake of that. And I think the government, the UK government, didn't want to do that. The English government in particular didn't want to do that because it didn't want to be shown to have failed on the pandemic. And I think that sort of lack of courage in terms of owning up and facing your mistakes and being accountable, being seen to be accountable, has been a major failing of the political classes during the pandemic, and that needs to be fixed. So in terms of values, I believe that they were absent during the pandemic, kind of values that we would hold dear. I'd also echo what Martin said in terms of the patient rights and the patient voice. As I say, that wasn't heard, but that extended to the staff voice. So I think the voice of frontline staff was largely ignored, and I think that's a major problem. The other issue to highlight is just this lack of learning. I think I've touched upon it, and when I spoke about the international experiences that we failed to learn from, I think countries behaved as if they were islands or they were unconnected to other countries, and that isn't the case. The pandemic was a global event, affected nations across the world, and the learning and the evidence and the experiences were readily shared, and what any one country did had an impact on another country. So to behave in an isolationist way was a terrible and grave mistake. The final point I'd like to bring out was that that hasn't been discussed yet is the effect that the pandemic had on inequalities, and in many health systems, not just the UK's, inequalities have been worsening pre-pandemic, and the pandemic just accelerated that deterioration. And there seems to be, and now we have the cost of living crisis, there seems to be an absence of foresight amongst political leaders to tackle inequalities and to address them. And I think we'll continue to pay for that for many years to come. Thanks, John.
That's excellent. Thank you, Cameron. And where your comments are leading are perfect for our next speaker before the whole panel discussion. So finally, within this session, I'm very pleased to introduce Dr. Mehrunisa Suleiman. Mehrunisa is Director of Medical Ethics and Law Education at the University of Oxford and is a medically trained bioethicist and public health researcher whose research focuses on questions in particular where religious and cultural views and values of patients, clinicians and researchers are pertinent. And again, I could give an extremely long introduction and won't, but we'll just say that we're particularly pleased to hear Dr. Suleiman's reflections today, given her leadership of the Health Foundation's COVID-19 Impact Inquiry, in which your work assessed the impact of the pandemic on health and health inequalities. So over to you.
Thank you so much, John, and thank you so much for inviting me to this panel, and to Kamran and Martin for laying the ground for what it is that I will be sharing with you. And very much it will be a lead on from what Kamran has just mentioned in terms of the impact of the pandemic on health inequalities. To answer this question of what the place of values are in decision making in relation to the pandemic, what we need to do is zoom out a little bit and travel back in time from the picture that Martin has provided, and to spend a few minutes thinking about the social determinants of health. What we did as part of the Health Foundation's COVID impact inquiry was to review and commission evidence to understand better the impact of the pandemic on health and health inequalities. And I will summarize the report that we published in July of last year. But essentially what it shows was that the nature of the UK's recovery from the 2008 financial crisis, the last major global shock we faced, has had a direct bearing on our experience of the pandemic, and that decades of austerity impacted who fell through the safety net during the pandemic. And it's crucially important that we learn from the lessons of the previous crisis and this current one, so that we can build a more resilient society. I'll talk a little bit about the overall picture of the UK and what that has meant, but then also drill down a little bit more into this question of inequalities. In terms of our overall experience in the UK, the evidence shows that although the pandemic challenged governments around the world, the UK was notable in entering the pandemic with life expectancy stalling for the first time in a century and falling for some. You may be wondering why this happens in a country as affluent as ours. And what we learned from the data is that the greatest influence on our health and opportunities for good health are factors that shape the conditions in which we born, grow, live, work, and age. And as Kamran alluded to, there are huge disparities in people's access to opportunities for good health. And what we've seen is that the political choices, the decisions that have been made following the 2008 financial crisis meant that public services had been frayed and the underlying economy and social fabric was weakened. And what this meant was that going into the pandemic, the UK's health, social, and economic assets were poorer, and that as a country, we were less resilient to withstand another external shock and were weaker compared to other countries. And what we found in addition to this sort of overall picture of the UK was that countries with the greatest improvements in healthy life expectancy over the previous decades experienced lower excess mortality during the early phases of the pandemic. But what we also saw was that countries with more equal improvements in healthy life expectancy also fared better. That means healthier and more equal societies are more resilient societies. So it's crucially important that we think about how we value health and ensuring fairer opportunities for good health going forwards. The other sort of key factor that I do want to talk about is this issue of inequalities. And behind these overall UK figures lies the unequal burden carried by different populations and different regions. And there are so many groups that have been disproportionately impacted. But the group that I want to focus on are families and communities that were financially worse off prior to the pandemic and are facing a worsening crisis as we move forwards. We know that COVID mortality in England was more than twice as high in the most deprived areas compared to the least deprived areas. But this was acutely problematic for working age people. So those younger than 65 in the most deprived areas were 4 times more likely to succumb to the virus than those in the least deprived areas. And there are a corollary of reasons that underlie these inequalities. But what I do want to spend a few minutes on is thinking about this safety net. What we see is that low rates and coverage of statutory sick pay and difficulties in accessing isolation payments that Martin alluded to had a huge impact on people's ability to self-isolate and increase their exposure. In fact, our statutory sick pay only covers an average of workers' earnings, and 2 million people who are the lowest paid workers are ineligible. Financial incentives to also keep working are very strong in the UK, with only 12% of average wages being covered by unemployment benefits compared to 50 to 60% in most other European countries. We have the lowest statutory sick pay and some of the lowest unemployment benefits in Europe. What it means is that our existing social security is designed towards incentivizing work rather than allowing a minimum standard of living for those outside of work. We do need to think very, very carefully about these sorts of choices and how our welfare system is designed. And we need to address these weaknesses in the welfare state in order to provide people with an adequate safety net to support them through both income and health shocks. I'll stop there because I'm sure there'll be plenty of opportunities for us to be having a wider discussion about these inequalities and the social determinants of health during the Q&A. Thank you, John.
Thank you ever so much, Mary. So that's a third excellent talk. Alex, Martin and Cameron, can I invite you as well, please, to turn on your cameras? And we have just over 15 minutes now for panel discussion. Alex, are you ready to pose a question on behalf of people who've contributed to the chat? So while Alex does that, or just before Alex does that, please do put your questions or comments on the chat, and we'll cover as much as we can. Alex.
Sure, yes. There are a couple of questions which people have asked, which members of the panel have answered to some extent. So I'll leave them for now, and perhaps we can come back to them if we've got time. There's a question from David Shaw at the University of Maastricht, and it's a question for Martin, but potentially other members of the panel, and it's about different COVID policies and values across the 4 UK nations. So Scotland and Wales are generally sort of more cautious. The rule of 6 was more liberal in England, so i.e. 6 households are able to meet rather than 2. 6 members of the household versus 2 in Scotland. And the UK government targeted misleading advertising to residents of Scotland and Wales, telling them that the rules had relaxed when that was only true in England. So what are the views, people's views on these different approaches and the kind of poor communication of public health messages?
So, yeah, Martin, perhaps you can start.
Yeah, sure. So first of all, I think at the scientific level and scientific advisory level, of course, there was communication, and the 4 CMOs were meeting regularly. However, the politics were very different, and we were talking frequently to people in the devolved administrations, and the sense that we got from them was that their issues were not being taken into account at all in Westminster. I have some first-hand experience of that in the international arena, where the devolved administrations, I don't want to go into too much detail, were being actively excluded. So there was I have personal knowledge of that. So there was a problem, but I think the politics were problematic, although the scientific collaboration was good. But the devolved administrations definitely felt left out of it.
Thanks, Martin. Cameron, you spoke about please come in.
Yeah. What were you going to say, John? I might talk about something different. Can I say what I was going to say? Then perhaps I could pick up on what you had in mind. I just wanted to, I think David asked a very interesting question about different policies and about how they were implemented. Just 2 points I want to make about that. Which number one, some of the policy making was driven by this misplaced notion around behavioural fatigue, that somehow the public would not continue to follow the measures that have been implemented to prevent transmission of SARS-CoV-2. We had any number of pieces in the BMJ explaining why this was not evidence-based. So that was one problem. And then the other problem was around leading by example. We had the famous trip by Dominic Cummings to Barnard Castle, and then since we've had all the revelations and the controversy around Partygate. So I think in 2 particular areas, the government failed. The English government particularly failed, and also I think it betrayed a lack of understanding of behavioral science. I think behavioral science really came to the fore during the pandemic, but the government failed, I think, to take it seriously in the way that it should have.
Thank you, and I won't pose a follow-on. I see Mary-Lisa has a hand up.
Yeah, John, just to add in response to that question and building off of what Martin was saying earlier, some of the work we did as part of the inquiry involved roundtable discussions with policy experts and public health leads in the devolved nations. And one of the things we were hearing from Scotland as well as in Wales was they were more successful in reaching out to charities, organizations on the ground, particularly organizations offering support for disabled people, other communities who were disproportionately impacted. And they were able to include those voices and those experiences in a more agile and reflexive way, in a way that potentially didn't happen through Westminster, as Martin was alluding to earlier.
And maybe
Can I make one more point, which is that I think there was a sort of sense of sort of exceptionalism, particularly in England, in the sense that we're different, it's not going to affect us, or we know better. And I think, there was a statement by one of the deputy CMOs about how somehow, a particular public health intervention was okay to have that in Africa, but it wasn't something that was necessary in England. And I think England in particular had that sense of exceptionalism around the science, around policy making. And I don't think Scotland, Wales and Northern Ireland did in the same way.
Thank you for that. And Mary-Lisa, I was just going to follow on with you, but also it would be interesting to know if you agree with that characterization, and assuming you do, how much is that mirrored through your own work? How much have you seen that mirrored in the way public health policy was promulgated and developed pre-pandemic, and then what we may see coming in the future?
It's a really good question, John. So I volunteered at the start of the pandemic, sort of providing some of the public health response in the east of England. And certainly sort of my first-hand experience was it was incredibly difficult to coordinate the response because of the sort of stringencies and strains from central government. And it's the sort of thing that we do need to be very, very mindful of and careful of in the future, that people on the ground who know organizations and have much more robust networks should be trusted, should be made to feel responsible for doing that sort of contact tracing and organization of services, but also that they're more agile, they're able to be more flexible to changing circumstances in the way that central government isn't. So yeah, lots of lessons there for us.
Thank you very much. Alex, is there another question you'd like to bring in?
Yes, indeed. So this is also a question from Martin. It's from Emily Griffiths. I'm not sure from where Emily Griffiths is. So it's about the quote that he gave from John Edmonds. When should academics engage with government-established advisory groups? And when should they set up alternative advisory groups?
Oh, well, I'm not sure John said that. The quote from John was about the not
okay.
having the situational awareness on care homes. No, I think that a plurality of advice can be helpful. Now, there are huge responsibilities that come with that. And of course, one of the problems that we have is that there have been other groups who have been quite disingenuous and spreading disinformation. It's not simple in any way. I think transparency is incredibly important in all of this. But we felt at the beginning that it was not acceptable in a representative democracy for decisions to be made on the basis of following the science, which was really prominent, if we could not see what the science was. And now we're not claiming it's cause and effect, but of course, just after we were set up, then the membership and the advice did come into the public domain. I think that was very important. I should stress, by the way, from Independent Sage, we've actually gone through and we've published a paper looking at our experience. We've never actually disagreed with anything that Sage ever said, never. But where we've been different is that we can go beyond what they do. So on the bits where we overlap, we've been completely consistent. Where we have differed is that we can actually engage much more with the public and with stakeholders, and we can look at the policy implications, and we can get feedback from people saying, hold on, this is our practical problem. So it's complementary, it's not a substitute, but I think you just do need to have that degree of transparency in getting the evidence out there. And that was what we were originally concerned with. And then when we started, we found that, in fact, there were a lot of people who were looking to us to help to interpret the information.
Thank you for that. I think that question was directly about independent SAFE. So I wonder, Alex, if you have further questions.
Yeah, there's a question from Dominic Wilkinson, who is one of the leads of one of the other work streams on the accelerator, based at the University of Oxford, and he's asked a question which I guess is more general for the whole of the panel, which is a question about what do we mean by values and ethical values for decision making. So he's given a hypothetical example which I'll try and go through quickly by way of illustration. So if you're choosing what to buy for lunch, you might consider the cost, the taste, how healthy the options are, the distance you have to walk, but how important each of these are and how much weight you give to these factors, your values in relation to the decision. And different people will reach different decisions because they prioritize different values in their lunch choice. So if you think about this in the pandemic decision making, there are clearly lots of different factors and pieces of scientific evidence, but also there are different values at stake. And we've heard some of these already, both in terms of the substance of decisions, equality, health impact, other impacts, and so on, and the process of decisions, so transparency and the involvement of different stakeholders and so on. So I wonder if the panel could say something about what they mean by values and ethical values for decision making.
Thanks, Alex. Cameron, you began your talk by enumerating some values, so I wonder if you'd like to start.
Well, I mean, I'm not sure Dominic's. I read his note. I don't think Dominic's asking a question. I think he's really clarifying, how values can interplay with decision making, and I think it's all a fair point. When I speak about values, I think they're, and I use those values that we use at the BMJ. They're really the values that we help us make decisions. Yeah, so we want our decisions on papers, there are some authors on the panel and possibly in the audience, and then what we'd like to publish is we'd like it to be evidence-based. We want it to be patient-centered, involve patients. We want to be open and transparent in the way that we publish, and we want to be courageous. So I suppose it feeds into our decision making, but also the process of the decision making. But it's largely about our values are sort of externally they're internally facing and externally facing. They're about how we operate as a journal, but also how we'd like to be seen and perceived in what we do. So I think if I'm saying we'd like what we do, what we've seen to be done publicly as being open, transparent, courageous, evidence-based, and patient-centered, I'd like to have seen that in policy making, and I'm not sure that's what happened.
Thanks, Cameron. Mary-Nisa, would you like to add anything here?
Oh, fabulous question. You need to get me to pipe down after a couple of minutes, John. Building on what Cameron's saying, values are incredibly important in informing decision making. And one of the key things that we're seeing from the pandemic, but also the global financial crisis, is what is it as a society that we value, and how do we use that to center our decision making? And this is where health and fair opportunities for good health is critical, and we need to move away from GDP and other economic measures as sort of our barometers for marking success as a society, because health is in and of itself incredibly important as a value, but also it provides us with this resilience longer term. And the fair opportunity, again, is critically important, because we need to be mitigating the inequalities that we're seeing in our society. So yeah, just gonna take another opportunity to sort of underline health and fair opportunities for good health.
Thank you for that. Martin, would you like to?
Yeah, I mean, again, we could talk on this for hours. So I think the key thing for me is that the values should, as far as possible, be made explicit. There are lots of situations in which the values actually clash. And in particular, I'm thinking about autonomy and reciprocity. I also think that they need to be made explicit in terms of our responsibility for others as to who we are, who others are. Who are we? Who are they? Because, of course, that has all sorts of issues in reinforcing and generating inequalities and so on. So I think it's absolutely crucial to understand that these exist. And also, I think, to constantly challenge our own views. You know, the question I always try to ask from anything is pro bono, who benefits? And to think that one through in terms of trying to understand why decisions are being made. And that's always been very helpful from my point of view. But they often do clash.
Thank you. And we're nearly at time. I want to pose a final question. The same question to all three of you, bearing in mind, again, that you, in terms of organizations and positions that you represent, these are plural. But I asked this question going to Martin as a member of Independence Age, Cameron as editor of a medical journal, and Mary-Nissa in relation to the work you've been doing with the Health Foundation. And the question is, even if the problems that each of you has identified, for example, in opacity or in relation to background inequalities and so on, even if those didn't feature, would you still see a particular role for your respective organization that I just listed if we faced a similar situation again? So is there something that you bring that is necessary and wouldn't otherwise be brought, even if we had a happier context within which to apply it?
So do you want me to start, John?
Please.
The first thing I would say, to be perfectly honest, and I said it in the chat, is that nobody should underestimate the amount of work that has been involved in Independence Age. We meet for 90 minutes every Thursday evening. We have our public briefings, all of the organization of that, writing the reports and things like that. And we've done that for 2.5 years now. And a few people have had to drop out because of the time commitment and the pressures and so on. But the idea that you could replicate this in other settings where you didn't think it's so important just wouldn't happen. It's a huge, entirely voluntary commitment. So I think the feedback we get has been immensely positive. Of course, we've had a lot of very nasty attacks, and you would expect that. That's not surprising. And our model has been copied elsewhere in Ireland and Australia, elsewhere. But replicating it is really challenging because of the effort involved.
Thank you, Cameron. Quickly, what role do you see for medical publishing?
Well, no, I absolutely agree. I mean, if we could do this for every single problem, that'd be amazing. But a bit like Martin said, we saw a 1,000-fold increase in submissions to the BMJ. We published at a higher rate than we've ever published in the history of the BMJ. But we still had the same number of staff. Our staff, it was a great effort, but now they're exhausted, they're tired. If I had 1 million people to employ, then perhaps we could do this for other conditions, but replicating is almost impossible. Can I answer a question that Kathy just raised on the chat, which is, our values versus the values of people making decisions? I think that's absolutely right. I think we probably do have different values. And I think the key value for me is are you prioritizing the economy? Is this a value or not? I mean, I'm not an ethicist. Or are you prioritizing people's health and well-being? And I think I'm in the business of prioritizing people's health and well-being. And if we could persuade society to do that, I think we'd be in a better place. Thank you, John.
Thank you. And the last word of this session goes to Mary-Nissa.
Thank you so much, John. I think it's a real strength of our democracy that independent organizations like the Health Foundation can commission evidence gathering, novel analysis, and we managed to do that in terms of absent voices, those digitally excluded prisoners and others whose experiences were part of what was synthesized within the inquiry. So absolutely, I think it's really, really important that these organizations exist and their work is possible.
Excellent. Thank you ever so much, everybody. Especially noting Martin's point about the time commitments with Independence Age. Those sorts of pressures are true for all of us, and it's really good of you all to have come today, and we can see the positive reactions from the audience. So I'm hopeful that you feel it was a good thing to have done. I'm pleased now to hand over chairing responsibilities to my colleague, Dr. Beth Kamunga-Okpodo. Beth has been working with me on the public health and health inequalities work stream of the Ethics Accelerator project. So I'm pleased to pass over to Beth, who will introduce the second panel.
Thanks, John, and thanks to all the speakers. Alex, could you just give me a thumbs up if you can hear me okay? And I'll assume everybody else can. Okay, thank you. So we have the second panel, which is looking at the challenges of real-time public ethics, incorporating ethic expertise in public decision-making. We're aiming to finish 5 to the hour, just to allow people to have a bit of a break and everything. And so I'll just get right into it so that we can manage to finish in time. So again, we have 3 speakers. I will introduce them as we go along. Our first speaker is Professor Sir Jonathan Montgomery. Sir Jonathan Montgomery is a professor of healthcare law at University College London and co-chair of the Moral and Ethical Advisory Group within Department of Health and Social Care. Jonathan was one of the authors of guidance on COVID critical care triage produced by the Intensive Care Society. Jonathan will be speaking for 15 to 20 minutes, and then I will introduce the other speakers immediately after him. We'll follow the same format of, if you have a question, please put them in the chat, and Alex will monitor that, and then we'll take all the questions at the end after all the speakers have had a go. Jonathan, please, the stage is yours. Thank you.
Thank you very much, Beth, and thank you to everyone involved in organising this meeting. I won't say any more thank yous because I know we're a bit short on time. I'm going to try and share reflections on some pieces of work I was involved with during the pandemic, and I put in the chat links to the documents I will talk about so that you can have a look at them yourselves later. But I'd like to start just by reflecting on some problems that I think are implicit in the premise of the idea of incorporating ethics expertise in public decision making. And they're a version of the question that Kathy Liddell raised at the end of the previous session. So first of all, we need to ask ourselves what we understand to be the nature of expertise in the idea of ethical expertise. And you can think of a number of ways in which we might think about that, and they'll lead you to different expectations about involvement. It could be that we are looking for ethical expertise to give us the best answer to the concrete problems, all things taken into account. And if we do that, we're very unlikely to get any consensus about what that answer is. Secondly, we might think that the involvement of ethical expertise is all about ensuring that decision makers are aware of the range of alternative approaches to ethical decision making, which, as everyone on the session will know, is quite wide. And of course, the problem with that is that you can't really guide decisions by explaining how complicated the question might be. Or thirdly, and I think more plausibly for the sorts of work that I've been engaged with, we might think that ethical expertise being involved in public decision making would be all about ensuring that there's proper analysis of the situations for ethically significant features, essentially reducing the risk that ethically important things are overlooked. So when we look at how we've gone about this, I think we should bear that in mind. Second issue about the premise is the balance between ethics and other forms of contributions. You might think about this about the challenge of ethical imperialism. So there's a difference between saying that something is not the best ethical solution from saying that it's unethical. But as soon as we think about those sorts of parameters, we might ask whether ethics is the right discipline for that, or maybe we're thinking about the parameters created by human rights. So we need to be clear that embedding ethical expertise is in itself slightly challenging. And then we have a problem around moral agency and the danger that incorporating ethical expertise might seem to undermine the importance of public decision makers recognizing their own personal responsibility for the moral dimensions of their decisions. And it may also be important to remind them that they are representatives. They're taking decisions in the public interest, not merely in the basis of their personal moral commitments. A particular issue we see regularly in the area of something like abortion. So we need to incorporate our ethical expertise without undermining the accountability of decision makers. And that's a similar issue to the following the science sort of questions. So I want to reflect on work that I was involved with during the pandemic in terms of what you might call intrinsic contextual features, which are likely to emerge in all pandemics, and some particularly extrinsic or contingent ones that seem to emerge significantly in this one. And the main intrinsic features, which I think we need to think through, we'll always have to deal with, is how you incorporate ethical expertise in circumstances where decision-making is urgent, where the evidence is uncertain and the knowledge is inevitably going to be evolving. So we found ourselves asked to do a number of pieces of work in really, really short timeframes. So I was part of a group giving advice on the ethics of digital contact tracing, which we produced and submitted to the government within 3 weeks of our first meeting. We may have been taken in by unrealistic timescales for deployment. You know, maybe we should have assumed it would take months, not weeks, for NHSX to get an app designed, and refused to give that rapid advice. But we took the brief at face value and we produced a letter to the Secretary of State within that period. Took another month for that to be published, which gave us quite a lot of flack for not having given any advice, even though it had already been submitted. But working on a 3-week timescale meant that our scope for public engagement was extremely limited, and we were able to convene some digital roundtables, but we weren't able to go to any form of broader consultation. And that meant that what you could do in terms of incorporating ethics advice in a small period depended a lot on the group of people you got together and the quality of advice and information that you had. And I'll come back to some of that very shortly. The other piece of work I want to mention was a piece of work involving guidance on critical care triage, which was commissioned by the Four Nations CMOs in late March and then decommissioned by them at the beginning of April. And the reason for the decommissioning was that the projections showed that the UK was unlikely to run out of critical care beds in the way that had originally been anticipated. So we thought we were doing something that had to be available to them for approval in a short period of time. We got quite far towards a draft in 10 days, but we were doing that in the context where we had very little evidence on critical care outcomes. But the key opportunity seemed to be to avoid the proliferation of guidance, and a key part of incorporating the ethics advice into public decision-making was the possibility that we might have achieved what one of my colleagues working on it described as the sort of Tolkien principle, one guidance to rule them all. And there was a lot of diplomacy behind the scenes to try and get to a stage where we could have consensus, all of which faded away when the work was decommissioned. So given those perceived contexts of urgency, of uncertainty and emerging but currently low quality data, we tried 2 different sorts of responses to incorporating ethics advice. The first was to phrase our advice conditionally. So in the letter that the Ethics Advisory Board to NHSX sent to the Secretary of State, we aimed to explain how we thought the Secretary of State should go about taking a decision, the sorts of questions that he or his advisor would need to answer in order to act ethically, both at the time and going forward. So we set out in our letter a series of values, the first of which, or set principles, the first of which was a principle of value. Did we have sufficient reason to think that there was net value to the public health by implementing digital contact tracing, which is linked to that principle of impact? Did we have a good enough reason to think it will be effective in limiting the spread of the disease? Did we adequately protect security and privacy of those who use the app? Would there be accountability for decision making that was made over it as it developed? And were we giving as much control as was possible to those who chose to engage in it? And we identified an example of the consideration at the time of using self-reporting as a trigger for notifications on the app for people to isolate, which makes a lot of sense in the context of asymptomatic transmission and the slowness of knowing whether or not people were actually infected by COVID as opposed to affected by something else. But our advice was that if self-reporting was used to trigger alerts, that would undermine public trust. And if public trust was undermined, the app couldn't be effective, therefore effectively undermining the value proposition that lay behind it. And we also noted that if they were to progress on that basis, it would be crucial that there was easy access to virological testing in place before you deployed it. And then we added some conditions for further accountability and development if the app was progressed. So what we essentially tried to do was to incorporate the ethical advice by saying, well, these are the questions you should ask yourselves and the values you begin to play. And we took a similar position in the paper we produced as a background paper for members of SAGE on COVID certification, trying to identify how various possible scientific situations related to the ethical arguments. So, for example, we had a typology of cases. Does the vaccine prevent transmission, or does it just protect people from being harmed themselves? We have a very different ethical framework, depending on whether those two things were in place. So if all the vaccine does is prevent people from harm, then certification is actually dangerous in relation to the transmission because of the full security it creates. So all of that was around conditional advice. In relation to the COVID care triage, we approached it in a slightly different way. And what we tried to do was to create an adaptive framework. So the basic idea was that the guidance would incorporate an ethical framework of what was at stake, driven primarily from capacity to benefit and avoiding any questions about the value of any particular lives, just whether the person's life could be saved. Secondly, a decision tool, which tried to make the best available evidence accessible to frontline clinicians. And the idea was that that tool would have been kept constantly under review. And as evidence of capacity to benefit improved, we would be able to give clearer guidelines to frontline clinicians. And thirdly, a tool to enable the NHS to manage its capacity through processes of mutual aid in order to avoid the need for those hard choices about triage to arise. So effectively, our approach to the embedding of ethical decision-making had a sort of front-loaded bit, what are the values at stake, and then some tools to enable those values to be deployed as evidence changed in an adaptive way. So those are things that seem to me we would likely to try again if we had another pandemic. But embedding ethical expertise into the actual decision-making proved pretty tricky because of various contingent features of our particular situation. The first of which was that it proved incredibly difficult, at least early in the pandemic, to identify who was taking decisions. And if you can't identify who's taking the decisions, it's really hard to offer any advice, really hard to offer it in a timely manner. So we found ourselves in the Ethics Advisory Board on the contact tracing app, as well as our letter to the Secretary of State. We pinged off a couple of emails at crucial points, one of them about moving from the to the Apple interface, supposedly more confidential and secure, because we thought probably this was the weekend in which the decision was being taken. We thought probably it was being taken in number 10 and not in the Department of Health and Social Care. And our best way of influencing that was to email the Chief Executive of NHSX saying, we think these things need to be fed into the decision-making process. And you can read the emails in the report that we published. So there's a real problem about knowing who's deciding and therefore how to influencing them. When you do know who's deciding, you need to think about how you can try and have some influence. So do you need to translate the principles as you understand them into politically actionable language that you think might be taken into account? The Moral Ethical Advisory Group gave some advice on the draft of the ethical framework for adult social care and took out the word solidarity, which it wanted to recommend because it was told that that was unlikely to land well. And a big part of this in a particular contingent framework is thinking, if I'm trying to achieve a better outcome, how can I hope to influence that? How much do I have to play the game that the decision makers are having? And there were lots of opportunities to give advice, really hard to tell which the ones were most likely to have impact. But my view was that you took every opportunity that you could in the hope that somehow something might feed in. So the Moral and Ethical Advisory Group spoke to any civil servants who wanted to come to it. We participated in a civil service teach-in for civil servants across the Westminster around ethics certification. When we were asked to push something into SAGE, we did that. We had little impact on the Joint Committee on Vaccine Immunology. When the Gove Review looked at certification, we offered our evidence, and we collaborated with other agencies on an individual basis around discussions. So trying to get ethical advice in there was essentially taking every opportunity that was available, even at some degree of risk. And that leads me on to so the first thing is about targeting decision makers with advice. Second issue of a context is about trust. And trust cuts in lots of different ways. We've heard a bit about transparency. Transparency is not always helpful in winning the trust of decision makers. So the work of the Ethics Advisory Board to the contact tracing app was significantly undermined by the perception of Secretary of State's advisors that it was a leaky board, and that undermined our ability to give advice. I pulled out of a particular Today programme interview, having decided I would basically accept invitations to speak about ethics because nobody else was, because I was advised that if I went on that programme, it was less likely that the advice would get heard by the Secretary of State, and less likely that advice would be taken in the future. So these are judgments that you make in the midst of a pandemic, which one would hope would be different in different pandemics. There's also something around the context of trust in terms of what connections people make between the advice you're giving and other dimensions of their perception of what was going on. So I've mentioned in relation to critical care triage, the point about whether or not there might be sufficient demand on the critical care beds to mean that we could meet it. And that raises a question about, in context, issuing guidance about critical care triage at the same time as you were seeking to reassure the public that there would be sufficient capacity, that would create conflicting messaging, which would undermine public confidence. And that's a reasonable position for someone at CMO level or NHS England level to take about their capacity. And of course, each nation would have its own view on that, if you like, above the ethical pay grade, although clearly there are ethical dimensions to it. There's also a set of questions about who is able to be transparent about what. Independent Sage had its own sense of its stakeholders and its responsibility to speak. But if you are a minister, you are subject to collective responsibility. If you're an advisory body within Department of Health and Social Care, as the Moral and Ethical Advisory Group was, you are bound by the framework of your terms of reference and accountability. If you're an individual advisor, you have a little bit more freedom, but you also have it and your personal integrity to think about. Each of those things leads to a slightly different set of parameters around the expectations of transparency. Government is entitled to expect it can receive confidential advice, but it's not entitled to keep secrets from the public. How do you locate ethical advice within that? And finally, in relation to the trust dimension, I share a couple of things that were said to me about the work that I was doing. Critical care guidance, I was told that it wasn't a good idea for the NHS to issue this because it would put the future of socialised medicine at risk because of the impact that the US media being able to portray the NHS as having set up yet more death panels would create. And a sense from that unless you really needed it, you wouldn't want to see the government committing to the idea that some people wouldn't get care that they could benefit from because they were selected out. Similarly, with digital contact tracing, a lot of pressure on the idea that this was a Trojan horse for a broader surveillance state, that would use the pandemic to change the nature of the state in which we live. So here you have to grapple with the contingent contextual issues that what seems to you to be a focused issue is seen by others to be one which is indicative of something much, much broader. And then finally, on the sort of contingent elements of giving advice in this pandemic, it was apparent as the pandemic unfolded that the environment became increasingly hostile in relation to government scrutiny. So the critical care guidance that I've mentioned was portrayed by Sunday Times journalists in their book Failures of State as a form of ageist Nazi extermination program. And that didn't help our relationship with the chief medical officer in terms of giving trusted advice. I went on the Today programme and they had absolutely no interest in the advice we were giving to the Secretary of State, which I've summarised earlier about the usefulness of contact tracing app. We were only asked on whether or not we were going to tell him he couldn't have the app that he wanted. So the substance of the ethics was not of any interest to that. In relation to COVID triage, the Department of Health and Social Care has been judicially reviewed for not giving guidance and threatened with judicial review for giving guidance that it hadn't given. And that creates a particular risk-averse context in the minds of civil servants. And of course, the environment in which we were working, as Martin indicated in terms of his slide on leadership, was an environment of Trump, post-truth politics, all of which radically changed the way in which you could think about having influence. So I think those are key things that struck me as a flavour of trying to do responsible ethical advice during this pandemic. And I conclude by just making a couple of observations. The first is that it is really important that people who understand and are interested and care about ethics are in the room, but it's equally important that there are people outside the room holding up a mirror to decisions and enabling us to have critical reflection. If you don't have people in the room, it's highly probable that ethical issues are overlooked. If you do have people in the room, of course, they risk being captured. So we want to have people who care about ethics close to decision making, but we also want to have people independent of that if we're going to have an effective system. So how do we evaluate our success in terms of incorporating ethical expertise into public decision making? Well, we want, I think, to reassure ourselves that the ethical perspectives that were deployed did capture the range of issues that are significant, so we didn't overlook things. We also want to ask ourselves whether there were some decisions that fell so far outside the boundaries of acceptability and the ethical implications are exposed that it's fair to call them unethical, as opposed to just a different ethical solution than the one we have. And absolutely, we should hold on to the expectation that the public are entitled to have the values on which decisions are based explained to them. So my key claim, my last remark, is that if we're thinking about the effective ethical advice, we should think about it as an ecosystem, and we shouldn't examine specific components, rather as I've done in this talk separately, as if they could achieve all the things we need from ethical advice each and every time it's offered. We should ask ourselves whether the net impact of the ecosystem that we have in place is that public decision making is sufficiently informed by ethical expertise. Thank you.
Thank you very much, Jonathan. And I can see the questions coming in, but we will save them until we've heard from our other speakers. So our next speaker is Dr. Heather Payne. So I'll just introduce her now. Dr. Heather Payne is a consultant pediatrician with practice and research expertise in disability, safeguarding, and substitute care. Dr. Payne is currently working as a senior medical advisor in the Welsh Government. During the pandemic, Dr. Payne has been a member of the Moral and Ethical Advisory Group and chaired the COVID-19 Moral and Ethical Guidance for Wales Advisory Group, a similar moral and ethical group for healthcare in Wales. You're welcome, Dr. Payne.
Thank you so much. It's a huge pleasure to be here and part of this as somebody who is not an expert in ethics. As you've heard, I'm just a paediatrician, obviously with a very clear interest in the well-being of the children and young people and everybody else in Wales, because working here in government as a professional advisor, not a policy lead, I'm the kind of worked example of everything that Jonathan has just talked about. And I had the huge advantage of being the Welsh representative for our Chief Medical Officer and Chief Nursing Officer for Wales on the MEAG, the Moral and Ethical Advisory Group you've just heard about. And so I was able to use that when it became absolutely clear that because of the different kind of political and social circumstances in Wales, and the fact that we have a hugely and increasingly diverging set of legal expectations in Wales. We have our own body of law. And so I set up the COVID-19 Moral and Ethical Advisory Group for Wales, CMEAG Wales is what I refer to it as. because again, it was very much a matter of who is making the decision, and helping my policy lead colleagues who are obviously directly advising Welsh ministers to make these decisions. And of course, you know, when you're getting advice on making a decision, you very quickly get to the point of, well, what was the question? What do you actually need to know, as opposed to, you know, what are you planning to do, rather than what might you do? So ours was a very focused and, you know, very clear about that there were limits to what we were trying to do in the group. And just to kind of set the scene, again, we do have a diverging legal system. We had the first children's rights legislation in the UK, Children's Rights Measure Wales 2011, but since then we've got the Social Services and Wellbeing Act 2014, the Wellbeing of Future Generations Act 2015, and also our new legislation coming into force next year on Quality and Engagement Act, with a duty of quality and a duty of candour coming in for health and social care services in Wales. So we set up this group, and the things that I'd just like to bring out were the fact that there were, you know, policy colleagues were faced with numerous decisions, and as you've heard, there was huge amounts of conflicting information coming in, about 1,000 papers on medRxiv per month, most of it which weren't peer reviewed, so you know, you had to look at them very carefully in terms of the evidence, and of course an awful lot of what we were hearing was very medically modelled. And the first point I want to make about the group that I chaired was that it was an incredibly broadly focused group. It was the broad citizen voice was involved, so we had representation from Equality and Human Rights Commission in Wales, commissioners for older people, children, disability, learning disability, Welsh language, also health and social care professionals, Black and ethnic minority communities, unions and faith groups, so that we really had a very wide representation from the third sector. What were the, we built on the work of the fantastic work of MEAG and worked on a statement of core values and principles, which again we published. It's I can put it in the link on the it's published on the Welsh Government website, and that was an incredibly helpful structure to help colleagues understand what were the values and principles by which they were making decisions. And to be perfectly honest, most of the time it was actually helping people. It was almost like a checklist for good decision making, again based on the MEAG one, about consultation. Fits in with social services and wellbeing and our policy document, A Healthier Wales, which is based on co-production, involving people who are involved in the decision. So again, it formalized that process. Just a few words about the issues that we addressed. And again, I was very clear to emphasize that this group, the Moral and Ethical Advisory Group for Wales, was not some kind of Jiminy Cricket sitting on people's shoulders telling them what to do. We did emphasize that what we were doing was helping people in how to decide, being aware that they had to justify any decision which appeared to impact differently on different groups. And we've already heard how important the pandemic was as a syndemic, relentlessly exposing existing inequalities. So we advised on DNA CPR decisions and problems that people had. These were problems of overwhelm that health systems had. And sometimes they came out with inappropriate responses. So those were helped to be modified by bringing them. That was after the event. It was brought into the advisory group. But once we had established ourselves as giving helpful advice that could help people put things right, we were getting things in advance. So we had questions about clinical prioritization for treatment escalation, balancing the 4 harms of COVID and non-pharmaceutical interventions, you know, the impairment of civil liberties, restriction of children, schools, that sort of thing, hospital visiting policies, again, the balance of visiting and access and infection control, administration of vaccine and the use of restraint for people with learning disabilities or lack of competence, vaccine prioritization, and again, some of that went to the JCVI, access to clinical ethics advice on the ground and support for NHS organisations, The fact that staff were experiencing moral distress and sometimes harm. And again, the recurring themes were about co-production, commitment to a social model, which the Welsh Government has had, the use of equality impact assessments early on, following the law. If you follow the law, actually, you rarely have to get to how many angels can actually dance on the head of a pin. The policy decisions need to be very clear in justifying how they have balanced competing rights and conflicting views. So we were very clear. We weren't telling people what to do. We were telling them how to decide. So for the future, we feel that there is still work in dealing with the backlog fairly. We're hoping to embed good decision making in government colleagues who are ultimately accountable. And the hanging question, I think, is when we talk about capacity to benefit, is that more medically modelled than it should be? So that's what we've done. I hope that's helpful, and look forward to hearing further Michael speaking and the further questions. Thank you.
Thank you very much. That was really interesting, and I'm sure we'll have a good discussion. Our final speaker is Professor Michael Parker. Professor Parker is the director of the Ethox Centre at the University of Oxford. He chaired the Nuffield Council on Bioethics Working Group on ethical aspects of research in global health emergencies. During COVID, he has been a core participant in SAGE and a member of the World Health Organization's COVID-19 Ethics and Governance Working Group. Excuse me. Outside of infectious disease ethics, for the past 10 years, Michael has been a member of the board and ethics lead for Genomics England, which is a company wholly owned by the Department of Health and Social Care. You're very welcome to share with us.
Thanks very much, Beth. Thanks for the invitation to be here today, and it's great to be on a panel with Heather and Jonathan. I'm looking forward, as Heather says, I'm looking forward to the discussion afterwards. I'll try to keep my comments reasonably brief, so we've got time for discussion, but I sort of organise my thoughts, and I'll try to avoid duplication with anything that Heather and Jonathan said earlier. I'm going to organise my thoughts under 3 headings, really. So one is sort of ethics advice during COVID. The second is all of the ethicists in these kind of situations. And thirdly, the ethics of committee membership, advisory committee membership. I think, as you know, this is a great meeting. I think it's really important that we reflect on the roles in which and the ways in which more attention can be brought to bear on the ethical dimensions of policy, and very quickly on this question or recognition of the fact that many of the policy decisions that need to be made are or have as a key part of them value judgments. So I think this is a really important piece of work, and these aspects are very often either in or unacknowledged parts of the policy making process. So it's great that we're here today talking about that. In a couple of sort of open up the discussion, I also think it's important to note the fact that the amount of direct ethics input into UK policy during COVID-19 has actually been very significant. I mean, Heather and Jonathan have just mentioned some of it. In my own case, as an ethicist, over the course of more than 2 years throughout the pandemic, I've attended more than 100 main SAGE meetings, an equal number at least of meetings of various SAGE subgroups, including the Vaccine Oversight Group, the Science Board of the Events Research Programme, SPIBE, and a range of other subgroups on children and education, mass gatherings, and so on. I could go on more, but Martin said earlier, all of this unpaid and voluntary, and I'd say I put in more than 1,000 hours over those 2 years of this time. So this is actually quite interesting. So for a government to have ethics input, the various advisory groups, and have ethics input into those subgroups, I think is without precedent. And it's likely to be, I think, one of the most sustained and intensive periods over which a government has had access to timely advice on policy involving in real time, if you put together all the sorts of things that people have talked about earlier. So against that background, I think it's actually important to ourselves what it is at this particular time through the forming of MEAG, my invitation by Patrick Vallance to play a role on SAGE and so on, that ethics has in fact been seen as important and relevant by policymakers. There are a whole range of ways in which it could be better, there could be more of it and so on. Yes, why has this happened? Why is this, and how can we build on it for the future? And I'm hoping we can reflect at least a little bit on that in the discussion. But I would want to challenge, to some extent at least, the narrative that ethics has not been central to the recovery process throughout COVID. I think it has been in many interesting and novel ways. So that's the sort of first bit. And the second is having, agreeing, I think we all agree that value judgments are central. Then this raises the question, what is the role of the ethicist in this kind of setting, in the context of an advisory committee? And Jonathan, some of his thoughts that, and I thought I'd add a few of mine. I think it's clear that once you're on an advisory group of this type, it's in general not the job of the ethicist to tell elected governments what they should do. And it's important that that's not the job of the scientific advisors either. That's, I'd say, in general, and I'll come to some exceptions in a minute, but I think that's important. And there are obviously some exceptions. But then if that's the case, what is the role? And I think I want to build a bit on what Heather said here. So I think there's sort of four things I'd want to say. Is I think was my role to ensure that decision makers were aware that policy making has an dimension, and encouraging them to see the importance of paying careful attention to this and to the making of value judgments. Secondly, bringing the moral significance of specific decisions to their attention, the fact that there is a moral dimension. I just call this mapping moral landscape, so setting out the ethical and moral implications of different available courses of action and the arguments in favour and against pursuing them. And then finally, providing tools for navigating these landscapes, and this is going to be concepts, arguments, and so on. So the kinds of tools that are needed to make moral judgments about different courses of action and to adjust them. So this is, Heather said, is about providing the tools to make, rather than telling decision makers what to do. And there are things that might be said in addition to that, but I'm aware of time, so I'll stop there with that one. And then finally, I want to say something about the ethics of committee membership and advisory roles, because I do think that's an unexplored or underexplored topic in the ethics literature, in the bioethics literature, and I think it's actually very important. I don't think enough work has been done on the ethics of advisory committee membership. So clearly, as Jonathan says, I think there is when you're in this kind of situation, there is to some extent a degree of collective responsibility for advice. So I was a member of SAGE over that period, and I have some responsibility for the advice that emerged from those things. And clearly there would be times, I think, when it would be appropriate to resign or speak out publicly. But that can't be the default every time. That can't be the sort of thing you do every week. So, the default position has to be to argue the case, to make the tools available, and to do the best job you can. And then there's an important ethical question about, well, what are the limits of that? Second, taking on as a senior advisor, such as SAGE, come responsibilities. And I think it's really important to ask ourselves what the nature and scope and the limits of those responsibilities are. And I don't think that's had as much attention as it ought to. Some of the most influential ethicists and moral philosophers in the UK who've played these kind of roles, such as Mary Warnock and Bernard Williams and so on, have struggled with exactly these kind of problems. And I think that literature is actually something I certainly would like to do more of. So I think we need more work on that. And there is always this difficult balance as an individual, as a sort of final point, which is, so before I joined SAGE, I wrote papers on resource allocation in the context of difficult decisions in intensive care units, for example, which was fairly controversial paper. And I wrote a paper on COVID-19, the COVID-19 contact tracing app, and argued about ethical aspects of that. When I joined SAGE, I stopped writing papers of that personal, but I'd be interested to think a bit more about what's the right way of thinking about it. So I'll draw to a close there, and I'm looking forward to the discussion. Thanks.
Thank you very much to all our speakers. There's just so many fascinating things. I have been making notes and have a list of questions, but I'll try to be a good chair and give other people a chance first before I go in with the things that were really interesting to me. So Alex, if you'd like to tell us what the first questions are.
Yeah, sure. Again, there are a couple of questions which have been answered, I guess, in part in the chat already. So I'll move to ones that haven't been answered, and perhaps we can come back to those if we've got time. So there's a question from Siobhan O'Sullivan, who's the Chief Bioethics Officer at Department of Health Ireland. She asks, while acknowledging the critical requirement for making explicit the values guiding decision making, perhaps the more challenging aspect is how these values are translated, applied, balanced, and the space for reasonable disagreement. So she asks whether the panelists have a view in respect of what practical steps we can take to address the practical application of ethical frameworks and values as part of ethical preparedness for future pandemics.
Yeah, Jonathan, would you like to have a go?
I'll have a go. Thanks, Siobhan. Always good to have a difficult question from a trusted colleague who's been grappling with this in Ireland. So I think when I went into the pandemic, I was a strong believer in the value of ethical frameworks. We had done work in 2007, creating an ethical framework for pandemic planning, which MEAG adopted at its first meeting as, until it had a better one, it would use that. What we saw, I think, and this relates a bit to one of the other questions that's in the chat, is that framework of fundamentally a bioethical approach to ethical planning didn't resonate with the way in which decisions were perceived in terms of conflicts between economics and health and the like. So we'd envisaged in 2007 that this framework would provide a language on which challenges and questions could be analysed and responses articulated, so that we could then have a sensible conversation using a language which we shared, even if we didn't necessarily interpret it in quite the same way. I think what we saw in this pandemic is that the languages that we used there were not the languages that the politicians perceived to be relevant to the questions that they had in place, although you could see some translating into it. So I suppose the dilemma we're left with is the response to that abandon the idea of anticipatory governance and the creation of frameworks on the basis that in every pandemic they will be ignored for whatever is the contemporary political discourse? Or do we think that this pandemic was quite unusual in the context of particular types of political leader in the USA and the UK, and what we loosely talked earlier on the slides as sort of post-truth, that sort of context? And I'm not sure I know the answer to that. I'm afraid at the moment my pessimistic view is that the proliferation of data sources, the difficulty of providing advice that is widely trusted, makes it more likely that frameworks will be less useful in the future than we anticipate, and that we should recognise that's something that's here to stay. And if you think that, then I think you focus on building up relationships and trying to get those advising governments to seek the advice and trust the advice of bioethicists, and that's just a continuing process we should do all the time. If I'm overly pessimistic, we should go back to the frameworks that we have in place, how they've been tweaked during the pandemic. So crudely, we could say Heather's work in Wales built on that work we done in 2007, enhanced the public engagement and the groups of voices that have been pretty silent in the production of it, so as to get a more satisfactory version, and has put in place an ethical framework. I think the jury's out, Beth, in terms of which of those is the better answer. I think it would be foolish to give up on the frameworks, but we may have to be realistic about the extent to which they're likely to be impactful going forward. And that would be my response.
Thank you. Excuse me. I don't know, Heather and Michael, if you have something you'd also like to reflect on.
Michael first, and then I'll come in.
No, you go first, Heather. Go on.
Well, just to follow on from Jonathan, again, and coming from Wales, you'd expect a rugby analogy. So you've got to play the game that's in front of you. And we do have a very, very different political environment in Wales, flatter government. we deal with the devolved things. A lot of macroeconomics is not devolved. So, we are in a different situation. However, things like committing to the Future Generations Act, well-being of future generations, which places duties on ministers to consider social cohesion, reducing inequality, because it's much easier to improve health than it is to reduce inequality. And regard for the Welsh language, a particular thing for us. So all these things, equipping our future citizens to be engaged, well-educated, concerned, promoting equality citizens. So that's the point of it. And that duty is already on Welsh ministers through that legislation. So that's the context that we can work with. We try to avoid giving people a hospital pass. We sometimes kick for touch, but basically, what we are doing is working within the setting that we have. I think we're a little bit more fortunate in some things in Wales, less than others, but I do think contextualizing things is important. Thanks.
Yeah, just to add a couple of thoughts to those. I think I'm not a fan of frameworks, to be honest, for a whole range of reasons. But one of the reasons I'm not in favour of it depends what you mean by a framework. But one thing it's important not to forget about a framework is that it doesn't, or very rarely answers questions for you. What it always requires further interpretation and judgment in practice. So you can narrow down and provide the terms around which that judgment which that judgment gets made, but it doesn't obviate the need for moral value judgments. In the end, so it can sometimes look like it solves a problem when in fact it changes the nature of the problem. But I think one of the things I'm not going to say anything about things that have happened inside SAGE meetings, but I think one of the sort of more generally one of the struggles that I've had is that sometimes policymakers will have a clear sense that science advice is not policy making. Generally speaking, that's a view that's taken. So scientists will tell you about the effectiveness and so on of various vaccines or possibly of non-pharmaceutical interventions of various kinds and so on. But when an ethicist speaks, it's sometimes perceived as policy making, as an attempt to do politics. And I think, one of the things that would be quite helpful to do, this is coming to Siobhan's question, is if, between now and the next pandemic, we could get a bit clearer about the ways in which value judgments are an essential part of good policy making, whether it's politicians or other people in this, and that they need to be provided with the tools that are going to enable them to understand and make those judgments. And so when an ethicist says, here's a range of considerations and here are some arguments in favor against different courses of action, the political class, as it were, or the policy-making class needs to understand that that's actually extremely valuable and important contribution. And there's a wariness, I think, about that at the moment.
Thank you. Alex, is there another question that we could take?
Yes, indeed. So there's a question next from Jessica Pickett from the University of Birmingham. And this, I guess, is a question, it's for the whole panel again. I guess it's about the kind of remit of bioethics in a sense. So she asked whether panelists have some reflections of where bioethics ends and societal ethics begins. So, for example, discussions of solidarity, future well-being, health versus economic values, or how they're approached in navigating the scope of ethical considerations, or whether they think these kind of distinctions are indeed meaningful.
Shall I go first this time? Just change the order a bit there.
Yeah.
So I wouldn't want to make a distinction between those two. It's vital that an ethicist in the kind of situations we've been discussing is able to raise clearly morally significant considerations such as this. And the range of things you just outlined, Alex. So separating them out, I think, has important risks. Really not want to go down that road. But I think what matters importantly is Jonathan's point earlier about roles. When the importance of having some people who are inside, as it were, getting involved in the policy making kind of process close to hand. Some people who are stepping back, having a range of different perspectives and perspectives in kind of two different senses. Perspectives as in the spatial sort of being close, being far away, etc., and perspectives in the other sense, that sort of things that Marinisha mentioned earlier, I think is absolutely vital. I really wouldn't want to see societal and other ethics kind of disaggregate it myself.
Then we can have Heather, then Jonathan.
Yeah, thanks. Do you know what? I think, again, I'm a great fan of working out, the practical implications. And I think that going forward, COVID's not even quite over, but it's mostly over. But going forward, we have massive indirect problems with our NHS waiting lists. So again, in health and social care, we have some fantastically huge issues to sort out. And so I think the questions are coming thick and fast about how do we prioritise people for care, as well as the Black and ethnic minority disparities, which is the First Minister's Advisory Group in Wales that I co-chaired with Judge Ray Singh, and produced socioeconomic report, which has led to an anti-racism action plan just about to be published by Welsh Government. There was also a report about the differential effects of COVID on people with disabilities called Locked Out, which again brought out this syndemic effect of the pandemic. And one, important question is what do we mean by the ability to benefit from treatment? And again, that's a phrase that frightens a lot of disabled people, and that's brought out in that report. So I think how we use QALYs as a measure of value, does it actually subserve all our communities? So I think there are some enormous practical questions. And as I say, I'm not an expert in ethics, and knowing my own limitations means that that's why I've surrounded myself with people who are experts in law, in rights, in ethics, as part of the group. But giving voice to all those different people as we address and try and advise on those questions is again an intensely practical aspect, which I'd just like to make sure that we see as part of it. Thanks.
Jonathan, please.
So I'm one of those people who's skeptical about the existence of bioethics. I think it's a sort of an activity that we've got involved with, and we've organised it in particular ways. We've got very interested in committees around bioethics, and I think that COVID, amongst other things, exposed the limitations of doing that work just as people who perceive themselves as knowing about bioethics. I saw during COVID sort of two main attempts to try and get some traction on this by creating ways of comparing outcomes in a way that's commensurable. And one of them basically said it's all about the social determinants of health and health outcomes, and therefore all our economic issues need to be translated into how much life expectancy, how many lives will it save. And the flip side of that was everything turned into money and saying which health interventions would be most efficient in terms of producing a healthy economy. It just seems to me that it's pretty obvious that those aren't very satisfactory, because as soon as you try and do it, you're immediately struck by the inadequacy of what they cover. So I think I wouldn't ask the question, where does bioethics end and societal ethics begin, so much that I'd ask, given the problems we're facing, what group of people do we need around the table thinking about it to try and reduce the risk that we miss something important? And can we convene a group like that? And can we get them sufficiently open-minded to discuss with each other and build it in a way that are sufficiently trusted by the people taking decisions that they have some hope of having some impact? So I'm not sure I'd focus on the differences between the disciplines and the approaches so much as building from the immediate problem upwards and saying, what do we know about it? And I think one of the things we saw, and this has been touched on in the first panel session, one of the things we saw was we had, as everybody always does, sort of blinkered view of what was at stake. So we focused on health and we downplayed the impact on social care. We focused on older people, a bit less on working age adults, and not very much on children. And you just need to constantly be alert to your blind spots and try and compensate those by having people know about those around the table. So that would be my sort of response to it not being about where one thing ends. They all overlap. So what is an appropriate deliberative process that brings that together? I would say that we now know that you can do decent public engagement and deliberation using digital tools and others, even when everybody is staying at home. Now, and had we had all that set up at the beginning of the pandemic, those sort of 10-day bits of ethics advice that I spoke about, we would have done those differently if we could easily have called on those things. So that certainly is something worth investing in, having in place in advance. Thank you.
Thank you. Yes, the other people in our ethics accelerator, like Jamie Webb, who I can see here, who've done some fascinating work that shows that there can still be deliberation, especially now with digital media and so on, even with short time frames. So if you just want to just direct message Jamie and just ask him for, or maybe Jamie, you can put it on the chat. There's so many questions that are still on the chat. I still have my questions and follow-up questions, but I had promised that would be done 5 to time, just so people can have a bit of a comfort break before the third session. But could we please use the reactions to thank our speakers and thank the different people who've been involved? It's just a reactions button and we can just thank our speakers. Thank you. So our next session begins at 1. So you have like around 4 minutes or so to just grab yourselves a cup of tea and so on. Please continue using the chat box before then. Thanks very much.
Hello and welcome everyone. This is the final session of our workshop. It's been brilliant so far, and I'm sure this session will be equally as sparkling. So I'm Professor James Wilson. I'm at the Department of Philosophy at UCL, and I'm one of the co-investigators on the Pandemic Ethics Accelerator. So this final session is called Anticipating, Identifying and Responding to Ethical Controversy and Uncertainty. And it's an enormous pleasure to welcome Professor Ilana Singh, who's the principal investigator of the Pandemic Ethics Accelerator, to lead off this session. So that Ilana is a professor of neuroscience and society at the Department of Psychiatry at the Oxford University. And she's also been co-director of the Wellcome Centre for Ethics and Humanities at the University of Oxford since 2017. So Ilana will speak for about 15 minutes, and then I'll bring in our 3 further speakers to make contributions after that. So in your own time, Ilana, take it away.
All right, so this is what I'm going to talk about. Our aims, what we think we offer as a collective, and where we've succeeded and struggled, and what we think should happen before the next time we have a national health emergency. I've taken this from the text that's on the website, in part because I sort of want to frame this as, here's what we thought we would be doing when we set out. And one of our initial ideas was really that the UK is an ethics powerhouse, as we've been hearing. And so one of the functions of this project was really to try to harness and mobilize that expertise. And I'm using expertise broadly because, you know, in our group, we have social scientists, we have bioethicists, we have people coming from a medical background, so expertise quite broadly, but people who work on ethical issues. And we really saw this as a national endeavor, an opportunity to build a platform in the same way that we had a COVID economics observatory already up and running, and other kinds of observatories. But we called it an accelerator because we wanted to accelerate the ethics rather than just observe them. And we also really saw a role for us in enabling a systematic public deliberation around key ethical issues, because we saw that this was a public demand, and we thought that we could really organize around that demand. And specifically here, the role of the Nuffield Council on Bioethics was really important to us, and we were just so pleased that Nuffield and Hugh Whittle were willing to join us in this collaborative. And then, of course, to think about strategies to embed ethics for future pandemic preparedness. And, you know, we've been using terms like pandemic resilience, pandemic recovery. Still not clear on what terms are the best terms, but I like resilience in the sense that it suggests that we're contributing something sustainable to the future. And so one kind of early signal of maybe that ethics wasn't as important as other matters, which is, you know, fair enough in a pandemic, is that the UKRI COVID-19 Research and Innovation Fund, on which, just to disclose, I was on the strategy committee looking at the portfolio of projects across that fund. It promised a response within 10 days. So this is something for the funders, I think, to reflect on, that was just not going to be possible. And so there was a kind of prioritization. And I think that the other thing that I learned as part of my role on that strategy committee was that there was a lot of dialogue with researchers in medical areas, sort of identifying the strategic needs and prioritizing, in a sense, those needs. So there was a lot of discussion through the MRC with researchers, for example, through NERC with researchers, but the AHRC, which was the part of UKRI that funded us, was not as actively discussing in the first instance with researchers the needs, and that came later. So the awareness of the lack of ethics in that portfolio actually came later. So we applied in May. We had a project ready to go. We had people in place to staff the positions, but we didn't hear until 6 months later. And so by that time, of course, we were already behind in the game, so to speak. And we started in January 2021, and we expect to finish in end of July, early August of this year. Thanks. And so here are the investigators. So early on, we thought this really should be a Four Nations project. Though we didn't think there was time. If we'd known it would take 6 months for a response, we would have worked harder to create a Four Nations project. But as it is, we have Oxford, Edinburgh, Bristol, UCL, and the Nuffield Council on Bioethics with a really important policy and communications role that's held within the Nuffield Council on Bioethics and Oxford. Thanks, Kieran. We sort of did we used a ground up approach to come up with our priority areas, in that, you know, I as the PI didn't have sort of a full sense of what our priority areas should be. And all along, we've really had these priority areas that are led by experts in the area who are on this call. So this was a sort of ground up idea of what priority areas are necessary and required for this pandemic. And of course, you know, as we went along, they merged into each other, and we have worked very much as a collaborative. That's something I'm very pleased and proud of, that we didn't sort of go off into our own silos. And one way that we did that was really through our early career researchers, who are the kind of core engine of this project. So each of these priority areas did do their own bit of work and had one or more early career researchers working on projects. But we also established these cross-cutting areas of interest, where I would say we've done less work to date, but these are priority areas going forward. So what we did was we essentially said, look, I mean, we've been hearing this in this morning, that, you know, we can't sort of come up with full-bodied ethical frameworks. It's not what's needed. We really need to have an agile system of response. And again, looking around at what the other sort of national observatories were doing, there was a lot of sort of responsive advice, rapid reviews, people really churning out work that had the academic imprint of rigor and systematicity. And I think that's important, that we weren't just sort of churning stuff out without a system. And we spent a lot of time thinking actually about our methods and trying to make sure that there was rigor and justification behind those methods, which I think is something we have to offer. So we did responsive advice, we did these rapid reviews, we had executive summaries, policy briefs we didn't end up doing very much on, for reasons I think that will become clear. We also wanted to have lay summaries, and we had a lot of funding available for commissioned ethics research. So this was part of our strategy to mobilize UK ethics excellence. And again, this was not just about ethicists. These were, you know, we considered ethics excellence to be in the public domain as well. And as I said, we had a fair amount of money available for that. And we also wanted to do some public dialogues to promote stakeholder engagement. So this was broad. I think looking at it, if for anyone who's run a project, this is a broad spec. And then this is actually from autumn of last year, just an analysis of what types of outputs we were generating by priority area. And what you can see here is that different priority areas chose to focus on different things. And by last autumn, we were still trying to focus on this rapid ethics response. But there were priority areas, you can see in the peach here, that were doing a lot of media as well. So there were some colleagues who were able to really harness the media as a kind of, they became go-to people for ethics debate and input. And I think the other nice thing about the accelerator is that we agreed at the start that we didn't need to speak as a unified voice. So there were differences of ethical opinion and ethical approach within the co-investigators. And we were able, I think, quite constructively to use that as a way of saying, you know, there is no one right answer to most of the questions that arise here, but that there are ways of thinking about these questions, there are ways of approaching these answers from different ethical angles, and they may lead us to different positions on what the right thing is to do. So I wanted to just point out where we've struggled particularly, because I've appreciated sort of the reflexivity in this, in speakers this morning. So I think it's what is clear and becoming increasingly clear to me the more we do this kind of collective reflection, is that there were a lot of networks who were out there, who exist, who were trying to impact ethics, who were trying to think about public trust, who were trying to generate dialogues. Really at all levels of society, these networks exist and have proliferated actually as a function of the pandemic. And I don't think we've established a good enough connection between that, you know, what I would call on the ground work. And I think that also includes in committee work. And especially this is true for third sector groups, and the kind of normative ethical analysis that we are able to bring. And so that's something that I think it needs to be an area of kind of real reflection and progress in the next, you know, 3 or 4 months of our work. I think we've struggled to make some policy impact. We've struggled even to engage policymakers. I mean, we were at the House of Commons last week in a really good session that some of you were part of, and that was really the first time I felt, gosh, you know, the people want to have this dialogue now. They want to listen, and perhaps that's just how the pandemic has moved, as people have the headspace now to do this. But I think we've not just struggled to penetrate. I think we've struggled to understand what the needs are and to make strategic decisions on how to help direct ethics analysis. And again, we don't come in thinking we have the right questions. We really wanted to bring tools and processes to the table, as others have said. We have had an ambiguous or lack of relationship with pandemic science leadership. I think, you know, we also had trouble sort of identifying where the leadership was. You know, it wasn't just Chris and Patrick, you know, there's leadership all the way down. And that's something that's an important lesson for us, actually, to understand what those layers of leadership are. And to really understand who's creating scientific strategic direction, where is it coming from? And as I said earlier, I think that AHRC within the UKRI has not been as proactive in helping us make these relationships, even though there's plenty of policy activity within UKRI. And perhaps AHRC in particular hasn't thought about that enough. And then finally, we have not been able to mobilize the UK ethics community. So we've failed on commissioning despite trying in a number of ways. And as I said, having a lot of money, and we have yet to figure out why that is. There has been, I think, a splintering of ethics, of the ethics community in different valuable and important activities, but we were not seen as a platform for ethics community mobilization, unfortunately. So I think what we're learning is that, you know, ethics is really part of everyday pandemic life, and that decision-making during a pandemic is essentially ethical across multiple societal levels, and it's not the realm of expertise. It's, you know, it's all of us. And it's us in our lives as citizens, and that kind of the fact that we all played multiple roles. We weren't just academics. We were also citizens. I think that's something we can think much more about as we go forward. What the kind of the ethical and moral opportunities are in helping people understand how important ethics is in everyday decision making. And that's because I think we haven't, you know, I just heard Mike Parker saying that ethics was acknowledged. I think maybe, and that's good to hear, but I don't know that was done in public. So in public settings, I think we missed opportunities to do basic things that we, you know, as academics would do all the time. You know, what are you talking about when you talk about a duty or a right or a sacrifice? What do those terms mean? Because clearly we don't have shared understandings. And it certainly would be better if we had not even a shared understanding, but a transparency of what we mean by these terms. Certainly we have kind of dismissed the fact that there are different underlying values, and that people don't agree on the sense of the right thing to do, and how we can respectfully explore those different underlying values with you know, the key role, the term here is respect for our differences, and that we do have tools, we have frameworks, we have processes, we have ways of thinking that really can support these debates and the decision making, and can get to not to the right place necessarily, but to more balanced kinds of arguments and more transparency and arguments that are better justified. And I know some people will say, oh my God, that sounds like it takes a long time. And it probably does take a bit of time to do it well, but we now have the opportunity in this period of recovery and resilience building to do this, really to try to institutionalize ethics in public debates and in societal everyday life. So our final quarter priorities really is that institutionalization of ethics, both in public and policy landscapes. And these are just some, you know, specific things that we're going to be doing. I think this capacity building within institutions and across society is really important. I've started saying to all parents who have kids who are about the same age as my kids, if they say they're going to take the philosophy and religion A-level, say yes, because no matter what they go on to do, it will give them incredibly valuable tools of reasoning, thinking and reasoning through very difficult, complex issues. And I think this really goes to our desire to build this resilience through ethics, so that ethics becomes really embedded in the core of decision making and public dialogue going forward. So we think, part of that core, this is sort of, these are final ideas that we're working through at the moment. The idea of grappling with ethical questions in plain sight through the full range of policy and public mechanisms. So as I said before, I don't think we even knew what that full range is, and we're just coming to glimpse it now. Committee work, decision-making up and down the various tiers. And also that goes for publics as well. Where are the public levers that we could access to help bring ethics into plain sight? What are the frameworks and expertise that we have that are considered useful and agile enough? And I think usefulness, utility, and agility have to go together in a situation like that. How can we build these plans to engage the public more into strategy and guidelines? Because for goodness sake, we've been really behind in that process. And of course, massively important, and perhaps most important, to listen to these voices that tend to get missed, that get dropped off, that get ignored, that are excluded as we try to, to make it as good a pandemic as possible for people in this period of recovery and resilience. Thank you.
Thank you very much indeed. And our next speaker is Dr. Anjana Ahuja, who's the Financial Times' award-winning science columnist. She's also the co-author of the widely acclaimed book, Spike, the Virus versus the People, which she wrote together with the Wellcome Trust director, Sir Jeremy Farrar, which was named as the Times' top science book of 2021. So that, Anjana, the floor is yours.
Thank you. Thanks very much. And thank you very much for inviting me to speak at this conference. I just want to make clear that I have no formal grounding in moral philosophy or ethical reasoning. So I'm very much offering reflections on this as a journalist. And so I should say what my role is as a science columnist and a commentator is to communicate on scientific issues of interest and concern to Financial Times readers, is to highlight uncertainty, to offer clarity, to hold those in positions of power accountable for their decisions, to point out inconsistencies in policy or where things just don't seem to make sense, to highlight and sometimes advocate different policy positions. And essentially during the pandemic, my role really was to help FT readers think their way through the pandemic. So early on in terms of ethical things, one of the things I wrote about was, for example, how ventilators might be rationed, as was happening in Italy at the time. But I expected to be mostly writing about the science of the virus, the development of vaccines and so on. But I did become increasingly confused by the government's broad ethical objective during the pandemic and who was formulating it. So my confusions were, was government policy aimed at saving lives? Was it preventing infection? Was it to keep society running? And remember, that phrase, saving the NHS, protecting the NHS, who will be saving it for? And where did the precautionary principle come in? I did actually, in preparation for this, go back to the Coronavirus Action Plan. And there did not seem, and I remember thinking this at the time, there did not seem to be an urgent objective to prevent infection, which seemed to me to be the key immediate thing that you needed to do to keep people safe in view of what was happening in other countries. And much of the government's actions, to me, presuppose that it was acceptable for people to be infected with a new virus where none of us had immunity, and that also that there were such a thing as acceptable deaths and collateral damage, particularly when it came to the perceived herd immunity strategy. And that seemed to me ethically problematic. It wasn't what other countries were doing, like Korea and Singapore, and they'd already had experience of SARS-1. So the things that were not clear to me were how UK decisions had been arrived at, the values and the thinking that were underpinning them. It was not clear to me who had access to power and ministers and who could therefore influence decisions. I was confused about why there was no cross-party committee. I didn't know who was ultimately accountable for the decisions, really. Was it SAGE? Was it ministers? I guess it's ministers, but still the decision-making process seemed very opaque. I wasn't clear what outside scrutiny any decisions had received. I wasn't clear how short-term consequences health consequences were being weighed against long-term health consequences. And I wasn't sure whose voices were being listened to, for example, business, healthcare workers, immunocompromised patients, etc. I wasn't clear, it was confusing to me in a public health crisis, who should we be listening to? Should it be national governments who have a democratic mandate? Or should we be listening to a global health institution such as the World Health Organization, who are experienced with dealing with infectious disease outbreaks? Another ethical issue that came up that bothered me was the fact that early in 2020 it was becoming very clear that marginalized groups, particularly ethnic minorities, were more likely to become infected, and once infected were at higher risk of bad outcomes. So it seemed to me that government policy seemed to be permitting racist outcomes in terms of health outcomes. And also other speakers have talked about the inequalities that arose. And I phrased it in one column as, the pandemic was splitting us into the shielded rich and the exposed poor. There seemed to be no explicit discussion about the rights and wrongs of exposing frontline health workers to an unknown virus. And just really, again, this idea that many decisions during the pandemic were underpinned by unclear objectives, opaque criteria, a lack of transparency and inconsistency. So, for example, it was very unclear to me what was driving the policies on masking, and particularly dropping masking. Was it infection numbers, vaccination rates, or was it political pressure? Consistency. I was confused about the message on child vaccination. Why was the JCVI reluctant to vaccinate children against COVID, given that we had a safe and effective vaccine, but we have a vaccine program for flu? So, why do we allow parents to decline measles vaccines, but we weren't allowing them to give their kids an approved vaccine? So, from my point of view, I was interested in those under the radar ethical issues. They became a really important focus for my FT columns through the pandemic because they bothered me. I couldn't understand the decisions and I had to explain them to readers or challenge them. And they made me think about very fundamental things. So what is the purpose of government in a health crisis? What are a government's duties and responsibilities to citizens? How are ethical considerations weighed and included in policy making? Where is the transparency so they can be debated and challenged outside Whitehall? And I covered those issues because I felt I could and I should as an outside observer that had some influence. And I really like Jonathan Montgomery's distinction of being inside and outside the room. And I felt I should be one of those people, not expert, but reasonably well informed. I should be outside the room asking those basic questions about the strategic objectives of government pandemic policy and how they were being formulated. And just on one last note, writing Spike with Jeremy Farrow was a really interesting experience because we spoke to people inside government and outside, modelers, people at WHO. And it was reassuring because it confirmed to me that real experts and ethicists and even those modelling the epidemic were also unsure of the government's objectives, reasoning and values. It seemed to be really as chaotic and disorganised, certainly at the beginning, as it appeared. So I felt I wasn't going completely mad in what I was writing. So I would like to leave it there. Thank you.
Thanks so much. That was really rich. There's so much to talk about in there. But I want to pass next to Victoria Butler-Cole QC, who's a barrister at 39 Essex Chambers, where she specialises in health and social care law. She's a member of the Council of Justice and also a member of the Nuffield Council on Bioethics. So the floor is yours, Victoria.
Thank you. And so my 5 minutes, wondering what lawyers can have to say that's useful about any of this, is probably quite negative overall, because the topic of this session, anticipating, identifying and responding to ethical controversy, I think one thing that law is really bad at is anticipating things, because judges like facts and they like evidence and they like certainty, and they don't like speculation and worries and general problems. They want something that they can really focus on and grapple with. And added to that problem is the problem that where something is difficult and raises ethical issues or questions of social policy or public policy, the courts have all sorts of formal and informal strategies for avoiding answering those questions because they often don't want to and don't feel that they're the right people to do it. And so you have sort of procedural barriers. So you have difficulties in questions of standing, who could bring a claim to a challenge to a government policy. Sometimes that's relatively easy if you want to argue about something on behalf of disabled people. A disabled person can bring the claim. It's a bit harder when you are trying to deal with something like race inequality. Can just an individual person bring that claim, or do you need something a little bit broader than that? Then you have internal procedural problems in the system of judicial review and challenging government decisions, one of which is that the defendant's evidence in a judicial review is basically assumed to be correct because the court process in judicial review doesn't involve testing evidence. And so there's a sort of procedural sort of simplistic approach taken, which is we'll just assume that this government department witnesses are telling the truth and that what they're saying is accurate. And so those sort of procedural problems then also are compounded by this general sense of deference to government and to policymakers. And that is then massively enhanced in the middle of a pandemic. There were all sorts of discussions about possible legal challenges where lawyers were expressly saying, well, we can't bring this challenge now because the court is just going to say, you must be joking, they've got other things to worry about. And the last thing they need is a judge footling around in one specific area and giving their brilliant ideas about what should be happening. So you have the sort of inherent sort of tendency of the judges to want to be careful about barging in, to recognise that policymakers have got a whole load of competing obligations, and the person who is in front of the judge arguing about what should happen is just one of the people who they have obligations to. And there are a whole load of other people who aren't in front of the judge who might have equally valid things to say that pull in different directions. And then against all of that, you have the judge's permanent worry that they mustn't get into the question of resources and resource allocation, because that's not a question that they can really deal with. So all of those factors, I think, combine to make bringing legal challenges during a pandemic really difficult, not impossible. And there were a couple of examples where courts did, or the threat of legal action was enough to make decisions be altered. And the obvious example that I know of is the change to the NICE guideline on critical care admission, where the original draft or the original guidance, which hadn't really been consulted on, said use this frailty scale developed for older adults, and didn't actually take into account that it wasn't appropriate to be used in relation to people with long-term disabilities. And that only needed a pre-action letter before the government to turn around and say, oops, for NICE to turn around and say, we'll rewrite that. But that's a one-off focused problem where it's very obvious that there's a mistake, and where experts are able to confirm it's a mistake rather than it just being the famous lefty lawyers arguing about something. So there were a lot of challenges that weren't brought or didn't go anywhere during the pandemic. But I think that there's a really interesting question about, now that we know what has happened, and now that we have more evidence and more will come out during the inquiry about what's happened, are there going to be more cases brought, either retrospectively about what happened, for example, the recent challenge to the decision to send people back into care homes without being properly tested and isolated, but also are there going to be attempts at legal challenges to do with the next pandemic, and the fact that some of these obvious problems and difficulties that we can now understand a bit better, whether a court now might be more willing to look at those and say, actually, yes, we can see that this happened, and we are willing to say something about the hypothetical future because we've got something concrete that we can base it on. So, and I think that will be relevant not just in relation to pandemics specifically, but also in relation to some of these wider problems that we already knew about, but now have even more evidence on, in particular, the evidence that we have in terms of racial inequality in health and what the impact is of that on particular groups of people. Those are my 5 minutes. Thank you.
Great, thanks so much, and great time beginning as well. Thanks very much indeed. I'll pass to the last of our commentators, who's Dr. Julian Sheether. He's a writer and ethicist. He's a special advisor in ethics and human rights to the BMA, and also an ethics advisor to Médecins Sans Frontières, and an independent consultant in humanitarian ethics. So yeah, the floor is yours, Julian.
Thanks very much. This has been really fascinating. From Victoria and Anjana, I can see exactly the kind of timetable. I can relive the moments that I was going through. But my job was a very straightforward one, really, which was you need to bring some guidance out. The BMA, the British Medical Association, for whom I work, we saw what was happening in Italy. We saw what was happening with the potential overwhelming of the intensive care beds in Italy, insufficient ventilators. This may well be coming to the UK. We need some guidance. Now, it's important to say straight out that obviously the guidance that I am providing, or the guidance that we were providing, was primarily for the British Medical Association. It is therefore part of the focus on that is on the interests, protecting the interests of our members who are doctors. Now, having said that and acknowledged that, at the same time, we can't put out any guidance that's not legally coherent and based on good ethical reasoning, because that's what you kind of do in an ethics department. So when this came, there was the question that we had no extant guidance, particularly on the issue around triage. We had nothing substantive relating to this particular issue. So what I did was I dug back into the files, I dug back into our kind of, the stuff that we've developed over the years. The previous pandemic, H5N1, which didn't come to much, we'd put some material out, that gathered that together. But I was also in a very lucky position because there were some great people on the BMA's Medical Ethics Committee. Because one of the questions, obviously, that has to arise here is on the basis of what authority do you as the BMA speak? We turned to the government, we looked to the government, we wanted centralised guidance, we wanted something that there was consensus about, that the legal risks had been analysed, but it wasn't there. And nor could it be developed in time, and there was an enormous reluctance. You get the moral queasiness around it, but the enormous reluctance to grasp the fact that you may have to set some people aside for non-treatment who may otherwise in other circumstances have benefited. That was the kind of ethical nub of it. And we saw a great reluctance in government to go anywhere near that. No, let's push that back. That's a job for doctors. But how are we going to go about making that decision? So we wrote some guidance, I say, and it was a very much a collective, it was sent rapidly around the ethics committee, the QCs on the ethics committee, lots, there were two great intensivists on the ethics committee. Clearly it was going to be in their bailiwick, and so we did it very rapidly. And then the day after we published it, that's when we got the legal claims coming in. We had one of the defence bodies coming in saying you're inciting people to murder. We had several city law firms saying we think your guidance is fundamentally discriminatory and unlawful. Everyone was concerned about the criteria for these kind of triage and allocative decisions. That was right at the nub of it. But a lot of the criticism was negative, saying these are the wrong criteria, but nobody was willing to put forward positive criteria. So how do you operate in those circumstances when you are being criticized for what you've put out, that it's not adequate, but nobody was willing to put forward a coherent set effectively of clinical criteria that you could use as a base for resource allocation in those circumstances. So that was the position in the end. And what we had to do was put our guidance out and defend it. This can be incredibly helpful if it's happening over a reasonable period of time and you're not right up against it. Obviously, it's a very productive process because you finesse it, you get it better, you make sure it becomes more dialogic, the production of it. But we didn't have much time, and we had members out there saying, look, we're going to be forced to make these decisions. Whether or not everyone likes it or not, we're going to be forced to make these decisions, and we don't want to do it unsupported. So obviously that's an important role for us to play, to step in. But there were other professional medical bodies also wanting to step in the field, also obviously understandably wanting to produce guidance. What happens if the guidance disagrees? How do you achieve some kinds of consensus? So those for us were the kind of central problems. And looking back, looking forward, one of the things we've got to come out with is a way of having some kind of guidance that's actually ready prepared so that we can respond, that there's a consensus emerges around it. Because to throw it back on individual organizations and moving out into enormous legal and ethical uncertainty to try and provide support for individuals working in these contexts is radically less than ideal. And that's my 5 minutes.
Thank you so much indeed. We're going to move now to a group discussion, and I could ask the other panelists to put all their cameras on. And is there any questions from the chat so far you'd like to highlight for us, Alex, and then we can move from there?
Yeah. So there are, in fact, Jonathan asked a couple of questions. Perhaps I'll run them together because one of them is to Anjana and the other is to Eleanor and Martin. So Jonathan asked, so Eleanor and Martin noted there's an issue about the government's apparent reluctance to use tried and tested mechanisms for engaging the public with contact tracing. And Martin McKee has added to that citizens' assemblies for bigger questions used by select committees, for example, social care. Jonathan goes on to ask, perhaps the government view was that they had been tried and failed. So how would we demonstrate that these methods are trustworthy so that future governments would be prepared to use them? And his question to Anjana is, he'd be interested to know whether she thinks that the current government behaves similarly in relation to other areas of its work. So to help understand whether it's mainly a question about this particular government or mainly a consequence of its specific response to the pandemic.
Shall I go first? So in terms of, I mean, this was an extraordinary crisis, first of all, and I've not had to cover a crisis like it. Most crises are kind of a war or an economic crisis, for example. So covering a health crisis of this magnitude, I've not covered one like this before. So I can't say how other governments would cover it. The one thing I would say is there may be a common thread is I wonder about the current government's approach to evidence and weighing evidence. So, for example, and I don't want to be party political about this, but I'm thinking about Brexit and the lack of a cost benefit analysis, which most of us would think was rather basic before going ahead with such a big thing. Extracting ourselves from the European Union. So I think there is, I think probably at the highest levels in terms of the civil service, as has been pointed out before, sort of lack people who have a really good grasp of science and scientific evidence and how to put those into policy making. And I think this was the kind of the ultimate crisis where scientific evidence needed to play a really big role. And part of that is knowing who to bring into the room and who can offer scrutiny on what you're trying to do. And what was interesting to me, I think, was the fact that, the government was sort of, I think, would have seen themselves as very pro-business, and they were acting with the business and an economy in mind. But actually, I had friends who were running businesses who were coming to me saying, we don't trust the government on this. What should we do? We don't think they're being cautious enough. So I found that sort of a really, really interesting sort of, position to be in.
One distinction that might be helpful for us for going forward was to distinguish two different sorts of ethics in play here, because on the one hand, we could talk about maybe the kind of ethics that ethicists often do, whether bioethics, thinking about questions about sort of ethics of critical triage or weighing one value against another. But there's also a broader sense of ethics. Maybe we could call it the ethics of public life, where it seemed that there's a whole set of principles, classically the Nolan principles of selflessness, integrity, objectivity, accountability, openness, honesty, leadership. And it seemed that some of the questions we talk about today seem to be about potential sort of failures to comply with those principles of ethics of public life, and others seem to come down much more to questions about, well, how do we get these particularly sort of knotty ethical questions which arise particularly in the context of the pandemic? How do we sort through those where there may be reasonable differences of opinion? And that, I mean, did you have a sense which of those sorts of levels of ethical dispute were actually in play at any moment? I got a sense from some of the things that you said, Anjana, and maybe Julian as well, that maybe what you thought that was probably at play was just a fact that the government hadn't really sort of done the basics right. They hadn't sort of followed what would be required by, for example, the Nolan principles of public life, quite apart from any of the actual substantive ethical questions that we needed them to ask.
If I'm just to jump in very briefly, I mean, one of the things that was frustrating and was the extreme reluctance of the government to step in. And there are many reasons behind that, but we've seen it in the past. There is a sustained reluctance on the government to get hold of resource allocation type decisions. They do not want to be seen to be the people making the decisions, making the kind of life and death type decisions. So they tend to be shunted back to the profession, and there is an incredible problem there, and fundamentally it is an issue about democratic deliberation about that kind of public ethics, which is very different to a decision about what looked like good and ethically robust criteria for resource allocation. And but certainly at the time when COVID blew in and when things were getting very urgent, this lack of, where do you turn? Where do you look? Where is the respected public debate about these issues that you can draw on? Many of us were in a position where the organisations we were working for saying we're going to have to generate it.
Could I bring you in on this, Victoria? Because it seemed that a number of the cases you mentioned, some of which went somewhere, and other cases it was determined there wasn't any kind of standing, seemed to be primarily about that, about the mode in which decision making was undertaken, whether as it were, the decision making was even kind of reasonable in Wednesbury terms and so on. So did you think that effectively we're dealing sometimes with questions of public ethics in that broader sense, in the Nolan principles kind of a way?
Yeah. I mean, at the moment, it's difficult to think that the Nolan principles still have any meaning, but assuming that they possibly will do again in the future, I think that there are some sort of aspects of ethics which the law is kind of happier grappling with. And so things to do with transparency and consultation and accountability and all of that, there's a sort of recognised way of dealing with those sorts of concepts. And there's a sort of baseline, which is, consultation is probably a good thing and so on. And whereas in things like, resource allocation and critical care beds, you can imagine that's just so much harder from a judge's point of view to sort of get involved in. And similarly, there's enough out there in terms of equality and discrimination that, again, those sorts of concepts are the ones that I think judges probably feel a bit more comfortable dealing with. And so I think there are definitely areas where you're more likely to be able to sort of get a foot in the door in terms of the court process. And some of the, if you look back now, actually, it would have been really helpful to have had someone bring a sort of public interest, challenge some of the COVID regulations and find out what it meant for something to be reasonably necessary for work, or, whether having a party in your own garden was all right. And, it might actually have been helpful for there to be more legal challenges to try and get some of that clarity at an earlier stage. And we did get it in some contexts. So there are other sort of court arenas where we did get some help. So there was guidance from the Court of Protection about what some of the COVID regulations meant in terms of spending time with family. And there were comments from Court of Protection judges about what the balance ought to be between protecting people in care homes and banning family members from visiting and so on. So you can sort of get some of this, but it seems to me that on some of the really important things, like Julian's guidance about resource allocation, as he says, the government doesn't want to do anything, so there isn't a policy that you can challenge. And then if the VMA produces a policy or some guidance, it's not binding on anyone necessarily, and it could be challenged. But at that point, that's one of the, I think, a really difficult, interesting question. If that guidance had been challenged, and I know people were thinking about bringing a challenge to it, what on earth would you have got out of a judge? And I remember at the time looking at some of the American states that have resource allocation policies that actually answer the question and say, ultimately, if it comes down to it, you prioritize the person who is younger over the person who is older. They actually get off the fence and stop sort of having a framework and actually answer the question. And I think it'd be really interesting, a really interesting question, whether if there ever was a policy here that went to that level of actually providing proper guidance that could be followed, what a court would make of it.
Can I come in here? It's really interesting because I offer a very crude level of commentary, really. I mean, I'm not an expert in ethics and so on, but, again, it goes back to Jonathan's idea of being the person outside the room that can look on at things and say, well, what is fair? What is reasonable? What makes sense? What's inconsistent? What's consistent? Because I think, interestingly, Victoria, I can absolutely see why people wouldn't want to say, well, actually, you prioritise young people over old people. and you wouldn't want to have that sort of really sort of formalized, because it then becomes challengeable, and it conflicts with, you know, legislation on equality and sort of you know, anti-ageism legislation. But on the other hand, if you stand outside, if you talk to people, as I did, if you talk to older people and they say, you know, what do you think about this? The vast majority of them would say, give the ventilator to the younger person, even if it means I miss out. And I think sometimes we forget, you can't see the wood for the trees. And I felt a little bit like that during the pandemic. I thought, is it just me, or are some of these things just a bit mad? Yes, we're getting really sort of het up about who gets the ventilator and who not. But actually, if you go outside, it's about having this public consultation, having a view on what people broadly think is the right thing to do. And that's the other thing, is that you're never going to get everybody agreeing on what the right thing to do is. But you can get surprisingly broad agreement about what's sensible in a crisis, I think.
Thanks, that's helpful.
Sorry.
I'll come to Ilona, sorry. Oh, sorry, after. Is it right if I come to Ilona, then to you, Julian?
Perfect.
Yeah.
I mean, it seems to me that one of the challenges here that I'm hearing in this panel, and I'm sure in the other panels as well, is just the multiplicity of, you know, views, guidance from different disciplines, from different types of professionals, among ethicists and the public. I mean, there's a question in the chat from Heather Payne about, you know, how do you reconcile all the different ethical statements? But equally, how do you reconcile, you know, different ways of approaching these questions from law and ethics? How do you reconcile all the voices that are in the public domain? I mean, and I really appreciate what you've said, and I agree, but also, you know, majority public opinion can be wrong from an ethical perspective. And so, you know, we can't just listen to the public, you know, we need to feed it into some form of an ethical way of reasoning through taking that into account. So, I mean, it seems to me that one of the anticipatory challenges we might set ourselves is doing, in a sense, a sort of meta-analysis of different clusters of pieces of work, so that we can maybe come up with some general statements about, you know, ethical guidance tended towards this, you know, legal frameworks tended towards this, public, you know, voices tended towards this on these particular areas, so that we can get clearer. I feel like it's a muddle, I suppose, I'm left with thinking things are a bit of a muddle at the moment.
Can I come to you, Julian?
Yes, thanks. I mean, Elena, it's a muddle with the menace of paralysis in it. That was one of the problems that we were trying to deal with, which is doctors saying, what am I going to do? And who's got my legal back if I am forced to make these decisions in the absence of anything like guidance? So that also, you know, from a kind of pragmatic kind of medical perspective, is the decisions are going to have to be made at some point. The worst possible outcome for us would have been doctors up and down the country saying, I don't want to make these decisions, I can't, because I feel unprotected, or just saying, well, nobody's got my back at all, but I'm simply going to wade in and do them because that's what the circumstances demand. So it's, you know, that's one of the big problems. We were menaced by paralysis. We were, that, you know, when we were bringing out the guidance and people were saying, well, you can't use that criterion, you can't, and I know I'm repeating myself here, you can't use that criterion. Okay, fine. Give us a criterion that is coherent, that will work in this context. We came up with something like capacity to benefit. You know, that's going to be a relevant criteria. Okay, but there's an awful lot of work to do when you got to at that point. But that start to look like morally coherent. And if we can get some kind of consensus around that, just saying these things are precisely the kind of things we can unbuckle them, uncouple them from concepts of disability, because that's one of the crucial issues when you're talking about capacity to benefit, when you're talking about underlying, health problems, you inevitably, there's the risk that has to be addressed and has to be thought through that you're going to be discriminating. So that, it's getting to that point where if it happens again tomorrow, if for some reason, monkeypox morphs into smallpox, morphs into something else, that people will be there in a position where they can say, well, these are generally accepted, reasonable criteria in these circumstances, which we may have to tweak, but they're front and center.
Thank you. That's very sort of helpful summing up of I guess, that particular moment of what things were like in late March 2020. I know that many of us who were around at the time had that sense of that it would be incredibly helpful if there was some guidance, and then there's a question of how to generate it. And there's a moment where it seemed like there were 5 or 6 different sets of critical triage guidance being developed in the UK and promulgated by slightly different groups. And we're coming pretty much to the end. I wanted to come back to Alex briefly, just sum up anything. I just pull out one question you think we could deal with in the last couple of minutes, or any points that have been made in the chat that maybe we should reflect on.
Yeah, sure. So in a sense, Julian has actually provided an answer to the question that I'm going to pose, but it'd be really helpful to know what the rest of the panel think. I mean, we've covered an awful lot of ground. There's a lot of confusion, a lot of complexity. So it's a question for Kate Jopling, who is a policy and communications consultant who's been doing some work with the Accelerator in recent months. And she asked earlier, she said it's just a straightforward question of what practical steps the panel would suggest to put us all in a better position next time for the future with respect to the embedding of values in public health decision making.
I think it's a great question. Who'd like to go first on that?
Okay, I'll go first. Never backwards and coming forwards, but I think the thing is that what worries me sometimes is that when you're inside the room, that experts can be captured, and I just want to come back on Elena's point. I'm not advocating for populist ethics, that I'm not arguing for that, but I am, but I do think sometimes some of these policies could be stress tested in I mean, politicians do it all the time with focus groups, and what sort of having some kind of mechanism by which you can have a sort of a reliable public consultation so that you can ask people what they think about certain things that may make perfect sense from sort of quite expert ethical principles inside the room, but actually just look slightly odd to people and people wouldn't relate to them. It's not how they live their lives. So just kind of having some sort of mechanism or architecture for public consultation, effective public consultation. How you do that in a crisis, I don't know, but just that I felt there was a mismatch between what expert groups were trying to achieve and what the public perceived those policies to be.
Thanks, that's really helpful. I'm going to pass to Julian next for his final words.
Sorry, just very quickly. I mean, one of the real difficulties there, Anjana, is that public consultation is one thing, but when it comes up against hard and fast rights, and you don't need very many people to say, okay, the majority may feel that it is appropriate to do X, Y, and Z, but my rights are fundamentally engaged here. And I totally plausibly get that from the view of the disability rights a movement over the years, because their rights and interests have been socially, systematically set back. So these are critical issues to work out. And unfortunately, under great pressure of circumstance, the public dialogue isn't very helpful. You do need to be able to make legally defensible decisions. And that's where the problem came.
Or actually to be up for the legal challenge. What we perceive as our rights and responsibilities are malleable. They have not been set in stone for centuries. They evolve, and I think there is a sense that sometimes it is about taking hard decisions as a leader or as a government, and actually being able to, or being willing to have those decisions challenged and being up for the challenge and understanding that's what it means to lead.
Thank you. So on that legal question, I'll come to Victoria for any final thoughts, and then to Eleanor to take us home.
So I was just thinking about this question about practical steps, and one of the things that I've been thinking about is that we have the COVID inquiry, obviously, which might take 4 years or it might take 40 years, who knows. There's already so much knowledge now about things that we need to sort out for next time, and so many, I think, ideas about things that we need to do on a sort of community and public front, as well as frameworks and guidance sort of front. And if we wait until the COVID inquiry has run its course and 8 billion emails have been disclosed and recommendations have been made, which the government then decides not to implement, nothing will have changed in a meaningful way before the next pandemic sort of hits us, and also potentially before other problems that could be improved from the knowledge we have from the pandemic, but which aren't directly pandemic related, could be sorted out. And so I think that the question about practical steps is a really important one, because who's going to do all of this? Who could do this? Who can actually try and harness what we already know without the kind of let's go back through everything that happened in great detail and find out exactly where it went wrong. Let's do the forward looking. What could we do better, and how could we start already thinking of ways of doing that, rather than perhaps waiting for years and years for the statutory inquiry to sort of run its course.
Thank you. And I'll come to Ilona now for the last word.
Gosh, well, thank you. So, I mean, I would go back. I mean, I was hinting at this before. I just think what needs to happen is that we need to create an infrastructure that is made up of people, methods, cases, and a view to what we need to make progress in these areas. I mean, and I think that the people are, you know, the people. We certainly should not be thinking in silos, as there's a comment in the chat. We need to be learning from each other about the places where these things don't work, you know, where we meet our paralytic moments, Julian, and why, and how we can overcome those. I think our methodologies for things like citizen juries, citizen assemblies, public dialogues can improve vastly. You know, politicians, you know, want scale. A lot of what we have trouble establishing in these quick public dialogue settings is scale. So can we use digital tools, for example, to achieve scale? And if we do that, then how do we, over the course of, you know, the anticipatory period, build capacity so that people can actually access and engage with these tools? You know, so we could do a lot better at that, and we could do a lot better at thinking about how to take those voices, that evidence, that data, and feed it into a, you know, ethical framework, normative thinking, in a way that doesn't just take it and do something with it, but then feeds it back in. And I think that, again, is an infrastructure question. And I think, you know, very practically speaking, what we need to do now is collect cases of things that worked and didn't work, and we need to work them through to really understand, you know, where are those pinch points and how can we make progress?
Well, that brings us to the end. I just wanted to thank all our speakers, not just from this session, but from the whole morning. It's been a terrific event. I feel I've learned an awful lot, and there's a lot to reflect on. So that, I mean, one thing to do, if you haven't checked out already, then you'll see all the outputs from the UK Pandemic Ethics Accelerator on our website. And there's a lot of things which take some of the questions we've been looking at today deeper. And for anyone who's missed part of the session or would like to recommend it to other people, we'll be making the recordings available in the next few days. So, well, with that, well, goodbye, and thank you all very much indeed for tuning in.